Good morning or afternoon, depending upon where you are, and welcome to the 6th Annual Online Clinical Educators Forum. I'm Mark Collop, and I've served as chair of the ASCO Clinical Affairs Committee, which is bringing you this forum through the support of the Clinical Directors Administrators SIG. We will acknowledge the entire Clinical Affairs Committee at the end of the program, but before we begin, I'd like to thank our 2020 OCEF co-chairs, Dr. Michael McGovern of SUNY and Dr. Greg Waldorf of MCPHS. Both are members of the Clinical Affairs Committee and both volunteered to steer this program and effort. I would also like to thank each of our presenters and Carol Brubaker, our Clinical Affairs Committee staff liaison and manager of professional affairs at ASCO. They all have been instrumental in bringing this forum to you today. Just a quick housekeeping note. If you're watching this as part of a group, which I realize is unlikely during COVID, please make sure that you have each attendee sign an attendance sheet. This is really important in helping us determine an accurate attendance count and will help us when we look for sponsorship for future programs. At the end of this program, the institutional liaison should send the attendance sheets to Carol Brubaker at ASCO. Lastly, at the end of the event, we ask that you please go to our SurveyMonkey evaluation link so we can assess today's program and utilize the information for future planning to better meet your needs. We have 4 excellent sessions prepared for you today. So without further ado, I'd like to introduce our 2 OCEF co-chairs, Dr. Michael McGovern and Dr. Greg Waldorf. Take it away, Michael.
Thank you, Dr. Collop, and thank you for your leadership as a chair of ASCO's Clinical Affairs Committee this past year, as well as for your strong support of OCEF 2020. Welcome, everyone. I am Michael McGovern, and I am the Chief Medical Officer at SUNY, as well as a member of ASCO's Clinical Affairs Committee. My OCEF 2020 co-chair, Dr. Greg Waldorf, and I started working on today's program well before the start of the pandemic. After reading survey results from prior OCEFs, as well as soliciting recommendations for topics and speakers from past OCEF attendees, as well as faculty who had not attended in past years, we put together a wish list of speakers and asked them to share their expertise as part of OCEF 2020. Greg and I are thrilled with today's stellar lineup of speakers and are grateful for their contributions to this program. So a big thank you to our 6 colleagues who will be presenting today. Before I hand it over to Greg, I would be remiss if I did not do one last thank you right at the outset. Ms. Carol Brubaker, our Clinical Affairs Committee staff liaison and our go-to person for all things OCEF, has been a tremendous resource in putting this program together. Her dedication, organization, and patience are appreciated more than Greg and I could possibly express. So a heartfelt, huge thank you to Carol. And now it is my pleasure to introduce my co-chair and partner in crime, Dr. Greg Waldorf.
Thank you, Dr. McGovern. My name is Greg Waldorf, and I'm the Associate Dean for Clinical Programs at the MCPHS University School of Optometry in Worcester, Massachusetts. I'm excited about this year's OCEF 2020 program because the topics are relevant and useful for clinic faculty. As clinical educators, we're at the cutting edge of technology in patient care. So rather than give you more of the same, today's presentations will challenge you to reflect on how you interact with students from different generations. It'll give you information on innovative uses of pharmacological agents and provide you with a background on compassionately caring for transgender patients. We hope you find these programs useful and applicable to your educational clinics. With that, I'm going to turn the program back over to Michael.
Thanks, Greg. Before I introduce our first speaker, I would like to let everyone know that we will be accepting questions, which the speakers will address at the conclusion of their presentations. You can submit questions at any time during the presentation by writing them in the box under the questions section on the gray control panel. So to get started, session 1, preparing students and supervisors for the transition from the didactic to clinical arena by Dr. Kimberly Lambretz. Just to give you a little background, the annual meeting of ASCO's Clinic Directors SIG was hosted last year by the University of Houston's College of Optometry. At that meeting, Dr. Lambretz gave the Dr. Les Kaplan Honorary Lecture. Her talk, which was built upon her personal journey as an educator, was incredibly candid, enlightening, and extremely well received. Greg and I, feeling that it could benefit both didactic and clinical instructors, as well as provide insight to all faculty, regardless of how many years they have been teaching, immediately thought it would be perfect for OCEF. We were naturally thrilled when she accepted our invitation to be part of today's program. To kick off OCEF 2020, it is my pleasure to introduce Dr. Kim Lambretz.
Good afternoon. My name is Kim Lambretz. and I've been asked to present to you today on preparing students and supervisors for the transition from didactic to clinic. But first I want to say a thank you to ASCO Clinic Directors Administrators SIG for sponsoring this program, and to Dr. McGovern and Waldorf for inviting me to present this material to you. And now a bit about me. I am the Associate Dean for Professional Studies and a clinical professor at the University of Houston College of Optometry. And I teach a course in the first year didactic program, the fall of the first year. I also teach in one of the laboratories in third year, and I see patients with our fourth year students in our surgical center where we're seeing perioperative, mostly cataract patients. I have a couple of disclaimers before we get started, and the first is that I am certainly no expert in the field of teaching or teaching pedagogy. And the second is that I realize that I am not going to be a successful YouTuber. I think that we all can agree that teaching in this COVID pandemic and doing things online, not in front of a live audience, is a little bit of a challenge, and I find it myself extremely challenging. So I'm going to do my best here and hopefully keep you engaged for the next 40 minutes. So in today's presentation, I'm going to be sharing with you my teaching story. I'm also going to be kind of revealing some of the realizations I came to as I reflected on my own teaching, and then what I did as far as my journey to become a better educator. And that's going to entail something called a teaching fellowship that was part of the Faculty Guild initiative. And we're going to be talking a bit about teaching objectives, reviewing some pedagogical themes and something we call tags, and then discussing the teaching peer review process using faculty circles and appreciative inquiry that I went through as part of my teaching fellowship. And at the end, I'll have some final thoughts and conclusions for you. So my teaching story began in August of 1997. Again, I came from New York at that time, where I was a staff member at a VA on Long Island. I was also part of a private practice and saw patients pretty much 6 days a week. I had no official classroom teaching experience. I did teach optometry students and residents while I was at the VA, but I had no formal teaching experience in a classroom setting. So I've been teaching my same Optometry 1 course for the past 22 years. And at the time I started teaching, PowerPoint was the new emerging technology of the day. And my course has always been well received by the students. But I noticed something over the course of time, and I really thought perhaps it was due to the generational difference between myself and the students I was teaching. Now, when I started teaching in 1997, and I'm just full disclosure, I am a very proud Generation Xer, but when I started my teaching journey, my students and I were basically in the same generation. By 2004, the students that were entering our program were pretty much millennials. And currently, the class that I'm teaching, they're mostly Generation Z folks. And so over the course of all these years, I've noticed a couple of things. One is my course was not as well received as it had been in the past. And of course, I thought it couldn't possibly be me. It must be simply the change in generation of the student I was teaching. But I also saw an increasing struggle building the or bridging the gap between didactic and clinic. And I thought to myself, you know, I think it's time that I really reevaluate my course, reevaluate my teaching, and what I was doing in the classroom. So I spent a good portion of last summer reflecting on and making some realizations. And self-awareness, as we all know, can be pretty painful as you introspect on things that you're doing and you really look at how and what and the why of teaching. It can be pretty painful. So I came to kind of a question, who can teach at the postgrad or professional school level? And the answer is those with credentials in the field. Certainly at the undergraduate level, graduate, postgraduate, and it's very true of professional schools in general, including medicine, pharmacy, and law. And I was never taught to teach, but I also, at the time, didn't actively seek this knowledge either. There are no certifications or additional degree requirements to teach in our programs, and we've been basically using a see one, do one, teach one principle. So ODs and other practitioners, including PhDs, are all experts in their field, and the assumption has always been that expertise in practice or research translates into proficiency in teaching. As experienced teachers, many of us develop our own conception of teaching and learning, and we form strategies to help our students. And really, we know that didactic courses do matter, but it's how we bridge that gap between the didactic and the clinical courses and how that translates to patient care that is our biggest challenge. Other things to sort of consider is, do you have an understanding of pedagogical principles and learning processes? And I know for me that I really did not have a good understanding of these things. And so I started out by looking at what is pedagogy in general. And pedagogy is commonly referred to as the act of teaching. And really, it's the theory and practice of learning, and there are many theories out there. As an academic discipline, it is the study of how knowledge and skills are imparted in an educational context, and it does consider the interactions that take place during learning. Again, right now, going through this COVID pandemic and many things are being done online, it can make this, or teaching in general, much more difficult, as we all probably are well aware. Conventionally, the teacher is the knowledge holder and the student is the recipient, and more currently, students are thought of as agents and the teacher is thought of more as a facilitator. One of the places that I went to go look was the Encyclopedia of Informal Education, and I looked up what is pedagogy, and there was something written by M.K. Smith, and he had some really good ideas and thoughts that I thought were pretty important. And one of the things that struck me is we often school our students, or we drill learning into people. And this has famously been called banking. That is, making deposits of knowledge. And this really resonated with me because I see it in my own students, and you may see it in your students, that things are very compartmentalized in a student as we're teaching them either different courses, no matter what year it is. And certainly things can get compartmentalized clinically as well. For instance, transitioning between a routine exam to an emergency patient can sometimes be difficult for our students. And I was kind of wondering whether that was because of this banking, where we're banking deposits of knowledge into a student and not giving them the tools or helping them to form connections with all of this information that we're giving them. And really, education should be a deliberate process of drawing out learning instead of depositing it. And we need to be encouraging, and we need to give time for a student to discover. Education should be a very intentional process. As we know, teaching is as old as time. Ancient Greeks and Romans had many philosophers, and they would stand and orate to their, the masses that would gather to listen. And then change occurred, and there was a separation of the activity of teaching from that which was being taught. And there was many landmark works published. One of the first was published in 1648, and the conclusions that came out of that work resonate today. And one of them was teaching must be in accordance with the student's stage of development. We all know that to be true. There's a big difference between a first year and a fourth year, for instance. All learning happens through the senses. It's not just a student reading something or sitting and listening, but learning happens through all the senses. Teaching should not cover too many subjects or themes at the same time, and teaching should proceed slowly and systematically. And all of these conclusions, I think, still resonate till today. So what do we actually want from our students? Well, we want to develop skills and practices that enable lifelong learning and independent problem solving and practice. We want student-centered active learning. We want the students to be able to apply, analyze, evaluate, and create, or higher order blooms. We don't want them just to remember or understand something or regurgitate it. But the real question is, there is a difference between my duty as an instructor and what my actual goal is. So my duty is to convey material to students. That's certainly true. We need to create and give assessments. We need to assign grades based on those assessments to every student in each course. But what is my actual goal? What knowledge do I want my students to possess? What things do I want them to be able to analyze or distinguish or calculate or examine? And where does all of this learning, where does this begin? Well, it really does begin in the classroom. So the first order of business is to lay the foundation in basic and clinical sciences for us in our profession. And then we move on to add some clinical practice. And those may be case-based, problem-based, evidence-based sort of learning activities. The last step in this process for most of our programs is to transition our students into full clinical practice, which is based on more higher order, more difficult case-based, problem-based learning activities and or just straight patient care. So that is the last step in this journey for the student. But it certainly does, in my opinion, start with the classroom. That is the foundation, and that is where we need to start to look if we're going to be successful in transitioning our students. So here's where my journey began as far as being a learner, and your journey may look very similar. So we all start out in a classroom, and in my case, my college classroom looked sort of similar to this. Optometry school, we had the famous overhead projector in the classroom setting. When I started teaching myself and I stood up in front of the class to give a lecture, I used 35mm slides and a projector. This was right before PowerPoint became the new technology. So I had a couple of revelations, I guess you'd call them, or reflections, as I was thinking about my own teaching, and it was, I venture to say, it was a very humbling experience. The students had changed, but I had not. How I taught my students had not changed much at all. And I realized that I was teaching my students how I was taught myself. I tended to lecture at them. Again, I made deposits of knowledge. I also found myself adding technology for the sake of adding it, without a huge amount of thought as to how it was going to, bolster the learning experience for the student or make the outcome or objectives I had in mind actually be learned by the student. So I didn't take a lot of that into account. And the other question is, how good am I really? If you leave it to the students, which many of our programs do, they're giving their evaluation of our teaching. A lot of times those evaluations do not have a lot of feedback or valuable feedback that is useful feedback to be used to change your teaching in the classroom. You get feedback that is potentially not very useful. We certainly review scholarly activity, but do we really peer review actual classroom teaching? A couple of other things that I realized is, how could I ever get better in my teaching if I had really no idea what is or wasn't working? How do I know my students are truly learning my material? Well, up until this point, I've sort of waited for the first exam or the final exam to tell me whether things were working. Another thing I learned was how little I really knew about teaching pedagogy or the language of teaching. And finally, and the hardest thing to learn was change is really hard and really time consuming. So I started by looking at my learning objectives. Now, I will say that up until this point, I had learning outcomes or objectives for my course, but I did not have individual learning objectives for each lecture. And I was never taught how to write a really good learning objective. I had a lot of objectives that were the student will know something, or the student will learn something, or the student will understand something. And these are just very vague, non-measurable objectives. And we all know today that when you write an objective, you really probably need to be looking at Bloom's, and everybody recognizes the Bloom pyramid, which starts out with remember and then moves to the higher order Bloom's, understand, apply, and so on. And so in 2011, Bloom's was revised a bit, and really, again, Bloom's is a way to categorize our learning objectives or goals. You're using action words or grunts or verbs to describe student behaviors. And there's a huge importance put on strong, organized objectives. And the reason that is these objectives define the purpose of your lecture. It clarifies what the student needs to do to meet an objective, and it aids the instructor to develop appropriate instruction, design valid assessments, and really ensure that the instruction and assessments are aligned with your objectives. Objectives should be smartly written. Something else that you need to consider. They need to be specific and measurable. The student needs to be able to attain those objectives. They need to be results focused and time focused. So I set out to evaluate every one of my lecture. I re-looked at all the objectives and the outcomes, if I had any, for each lecture. I knew that I wanted to offer assessment and feedback opportunities for each lecture topic. I was thinking of having some kind of discussion forum built in, and then I wanted to try and bridge the gap and make connections with the students so they would have an easier time making the transition from a didactic student to a clinical student. But I realized something, that I really did need some help. So the true beginning for me was when I decided it was time to ask for some help. And so what I did was I met with the Faculty Engagement and Development Office on our campus. And that office has instructional designers that have expertise in course development and educational pedagogy. And they recommended me to something called a Reflective Teaching Fellowship. And that was through the Faculty Guild Institute. I have some resources on the Faculty Guild Institute for you here. As of January of this year, the Faculty Guild Institute is now called Lumen Circles, but it involved hundreds of faculty at dozens of colleges and universities across the country. And the method has been evaluated by the Stanford Research Institute and documented in the book Taking College Seriously, Pedagogy Matters, Fostering Student Success Through Faculty-Centered Practice Improvement. And it's based on three main fundamentals. And the first one is teaching circles, the second one is reflections, and the third one is evidence-based instructional practices. So in overview of the fellowship, to give you a sense of what this was, each fellowship was 15 weeks long. And as a member, you were placed in something called a faculty circle, which was a group of your peers. You went through a process called meta-reflection, and we're going to talk about each of these things individually in a minute. But you went through this process of meta-reflection on your teaching in general. It was looking at your teaching philosophy, etc. Next, we went on to discover teaching themes, which was really teaching pedagogy, and then descriptors of the activities that we called tags for each of those themes. Next was reflective practice. So every week, we each that were in this fellowship would reflect on our teaching for the week, and we had to write out our thoughts, your objectives for your weekly session, and so on. And we'll go through what those look like. So you wrote this weekly reflection on your teaching. The next part was that we peer reviewed and were peer reviewed by our circle mates. So each week we reviewed others' written reflections on their teaching, and we received weekly reviews or feedback on our own reflections that we had submitted. Along the way, there were checkpoints where we could sort of take an inventory of what kinds of things we were learning and how we were doing, and what things were working in our teaching and what things weren't. We had facilitator input and help along the way to guide us. And then at the end, there was a final analysis, sort of an inventory of what things that you had done over the course of the 15 weeks that worked, and some room for improvement and things you could take going forward to help you along the way. And really this process was meant to, I guess I like to call it, stop and smell the roses. And what I mean is to take a step back and reevaluate teaching. Maybe not meta reflection every week, but reflecting on the one lecture or one or two lectures that you did for that week, and just really dive into it and see what it is that you did that week and how it was working. And this was really, really valuable stuff. So a little bit about the meta reflection. So before you begin your 15-week long fellowship, you did this meta reflection where you developed your teaching philosophy if you didn't already have one. And what a teaching philosophy is basically a statement, or what they call a reflective essay, about your teaching beliefs and practices. So it is a narrative that includes not only your beliefs about teaching and learning, but also ways in which you enact those things in the classroom. And so it may start with something that says, I believe, or I base my teaching on. It's really what you truly believe in the classroom, the lab, or the clinic. We also set some goals for ourselves with our teaching. We had the opportunity to take an inventory of the familiar and unfamiliar teaching pedagogy themes, and the individual tags or actual acts of teaching that go with those themes. And it gave us a really nice opportunity to explore all of that in pretty good detail. Our teaching circles were just our teaching peers, and these were faculty in similar disciplines, and my teaching circle was made up of healthcare and related fields. So there was about 8 or so faculty members in my teaching circle. Not all of them were from my own institution. These were faculty from all over the country, and we were able to connect with each other, collaborate, certainly reflect. We were able to share ideas, learn from each other, and otherwise engage when we would not normally have had that opportunity. So the reflective practice was really designed to increase our mindfulness and purposeful teaching. And so again, for a weekly assignment, we reflected on a recent teaching moment, and we had to redefine the objectives for that particular class period. And then we had to discuss in our written reflection, what did we actually do that day? What things did you do in class that day? And these are referred to as tags. We then had to decide what worked and how did we know it worked, and what might not have worked or what we thought could have been better. The collaborate part of this was, once we were done, we did use peer review process using appreciative inquiry of each of those written teaching reflections. So we offered positive feedback to our peers We may have asked probing questions. And so appreciative inquiry is really more, instead of saying, you should have done this during that particular class, it would be more like, how about if you tried this particular thing? Or what would have happened if you did this? So it's more positive feedback. It offered actionable suggestions and ideas for improvement for our peers, as well as being extremely helpful to me, reading somebody else's take on what I was teaching. I had never had anybody look at my teaching in this kind of depth before. Now, we all were not from the same discipline. Again, there was nursing and kinesiology, and it wasn't that I had to be a content expert in your particular discipline, but that I was able to reflect on just the teaching aspects of this. So it was extremely helpful, I think, to all of us that went through this. The last bit of our weekly reflections were to plan what could be done for next time I taught that particular topic or that particular class. So the themes, the pedagogical themes that are used for this exercise were supportive, challenging, varied, and organized. So the supportive theme were, how do we build connections between our students while they're learning how to be successful? Challenging was optimizing student learning by gathering and sharing data. Varied would be making learning personal and relevant for a diverse set of learners. And then organized would be promoting understanding and application of content by breaking down complex concepts. So those were the 4 themes that we worked under. Each of these themes then were further defined by things we call tags, which are really the teaching activities that were under each of these themes. So the tags under the supportive theme were caring, community building, etc. Under challenging was baseline knowledge, assessment, feedback, self-reflection, high expectations, and higher order thinking. Varied had differentiated instruction, multimodal instruction, etc. I'll let you read these. And under organized, there were 4 additional tags. Now, how did this really work? Again, we reflected on an up-and-coming class. We wrote out what the topic of that lecture was going to be, and then we had to make sure that we recorded SMART objectives for that day. And again, they had to be specific and measurable, etc. So building your learning objectives, again, you had to select what the student was actually going to learn, some specific skill or knowledge or ability. Then you chose the level of cognition using Bloom's. You selected a measurable verb, and then you had to make sure that you had some criteria by which you were going to measure achievement of that particular objective. Again, objectives certainly do define behaviors, not only didactically, but clinically as well. And so I had to get out of the vague, understand, comprehend type objective and really hit on the more measurable, SMART objectives, which was really not an easy task. I found this particular Bloom's pyramid to be very helpful to me. It is very similar to the others, but I found the way this was set up to be very helpful. This can be found on www.getsmarter.com, but I had this next to me as I was building my objectives for a particular class period or lecture that I was going to be reflecting on. And I chose to work on tags. You cannot, change the entire makeup of a course or the makeup of a lecture necessarily. You can't do everything at once. So I chose some places where I wanted to start. And I had no idea what some of these things were. I had no idea what multimodal instruction or differentiated instruction was. I didn't know what scaffolding was. So I had a lot of work to do to understand and sort of actively look up what constituted these tags. But I knew I really wanted to start with baseline knowledge, assessment, and feedback because I knew that these were things that were definitely lacking from my lectures. So I started with these three first. And so just to give you an example, I don't want to go through this in huge detail, but for baseline knowledge and feedback, what I did for my class is I made sure that I had students look at pre-lab module videos that had built-in sort of mini assessment or quizzes. I used PowerPoints that had built-in assessments for baseline knowledge. I made sure that some of these things were low stakes, meaning they did not factor into a student's grade, but then others I tracked how many times the student viewed it, and that did affect their grade. I made voiceover PowerPoints of more difficult material that had students pre-watch, very small snippets of time, so 10 minutes or something, just to review a topic prior to class. I am not a clicker person, so using a true audience response system in class was not for me. So I tried to find something that would work a little bit better, and I found something called Kahoot. Kahoot.com is the website if you want to go check this out. It's a very engaging, kind of cost-effective, low or high stakes type of assessment. This is the assessment mode that was used on the student optometry bowl, for instance, used during academy for the ESLOR student challenge. And it is very cheesy, though. I'm just going to warn you ahead of time. Very, very cheesy. It has background music that sort of sounds like a game show, but I'll tell you, these students really, really enjoyed doing it. And so that's where not only was I able to assess baseline knowledge with students, I gave them a Kahoot, call it a Kahoot, I gave them a Kahoot before the start of my lecture to see where they were knowledge-wise, but they really liked it, and so that also hit on the enjoyment tag. It helped focus my lectures going forward. I also did a post-lecture assessment too to see if they got the material finally at the end of the day. So again, this was a very, very useful tool for me in class, and the students really got a kick out of it. Next, I looked at how I was delivering my material, and I had been a PowerPointer, I guess, for 20 some odd years, but I tried to incorporate some other modes of delivery, such as team-based learning. I haven't mastered the entire flip the classroom yet, but all of these things, or some combination of these things, is what I really wanted to incorporate. I wanted to avoid the info dump or cognitive overload. I wanted to see if there was a better way to express my material. I wanted to teach with clarity, and I wanted the students to use multiple senses, not just their ears or eyes. Students gloss over boring things, so I wanted to keep it interesting. So I want to spend just a minute or two talking about the tag application, just to give you a better sense of how this works. So for enjoyment, the tag enjoyment, we know that a fun environment is conducive to learning. So things to add in would be demos or props, and I use demo and props during lecture all the time, trying to come up with creative things. Kahoot, again, was very enjoyable. That's an assessment tool, very enjoyable for the student. And I also incorporated team-based learning to a couple of the lectures. I didn't do the entire class in that manner, but I did do a few lectures using TBL, and the students really responded to that as well. For connections, the tag connections, I wanted to help the students make connections not only between topics and ideas, but prior knowledge and experience as well. And so one of the big things in the whole purpose of our being is to make our students great clinicians. And so how do we bridge the gap and integrate? And so even as first year students, I wanted to try to integrate making connections for these students as well. And so I developed what I call Doc Connects. And so I sprinkled in these slides within my PowerPoint that just simply said Doc Connects on it. And I had just little statements or questions that would enable the students to integrate either something in their personal life to a patient care, or it would integrate If we were talking about visual acuity, it would spark them from their own experience to think about, what we're learning really does mean something in real life. And so I've done that for the last year or so, and it seems to be working pretty well. You can make up connections between lots of things. It can be done in any course. And it seems, for me, it seems like it's working pretty well. I allow the students also to give me their feedback and give me some connections that they've experienced. And I usually do that in a forum, kind of discussion type forum way, method. And it seems to be working pretty well. For multimodal tag, this is presenting the same material in different ways. Again, making sure to hit not just, visual, not just speaking, but hands-on type things. And our students obviously have a lab that's associated with my course, but in the middle of my course, I do use some props, and here's my cheesy demo eyeballs that I use when we talk about cover test. And the nice thing about this is it uses some student participation. A student holds the cover paddle as we're talking about eye motions. And again, a very simple, silly thing, but when you present the material in a PowerPoint and then you stop and you demo it in real life, holding up silly fake eyeballs with eyelashes attached, it seems that this really resonates with students. One of the nice articles that I found, if you're interested in this, it's an article by Lorena Marchetti and Peter Cullen called The Multimodal Approach in the Classroom for Creative Learning and Teaching. So that is a really good article if you're interested in this topic. Differentiated instruction tag is a mix of activities within the same class period because we know diverse activities for diverse needs of our students. And I incorporated PowerPoint and whiteboard into many lectures. I would have Kahoot, which is, again, something that I use quite often, and then TBL. I didn't do these in every single class period, but trying to get a mix of activities within the same class is very useful. There could be an entire semester of discussion regarding team-based learning, so I won't go into all of that here, but I did use this occasionally in class and the students responded well to it. The other tag that I looked at was structured lessons and scaffolding, and that sort of presenting ideas in a logical progression, as well as sequencing activities that build on one another. And so I came up with this group grid activity. Now these are first years, they're just learning retinoscopy and what a prescription is. So I had them do a group activity where for them this was difficult. They had to draw out an optical cross, and then they had to categorize the type of astigmatism it was. And I had students break up into groups of 10, work on this as a group. And what I found was that the students really did teach each other, learn from each other, and really enjoyed this. And we at the end, everybody held up their answers, and the best, or the student group with the most correct answers, got a prize. It was really received quite well. So now what? So this reflective teaching fellowship is over. We reflected and responded to our peer circles for 12 to 15 weeks. We did our meta reflections and skills checkpoints, and we were able to review the results of that. We redefined teaching goals and philosophy, and we continue to add to something we call the idea draw, that is collecting ideas to be used in future classes. So I tended to use some themes and some tags more often than others. Some I didn't use at all. And so now I can go back and I can look to see, is there a way for me to incorporate some of these other themes or tags that maybe I didn't use or didn't use much into my teaching as I go forward. We can apply a lot of these principles to clinic. So having students reflect on the day is one of the things that I incorporated into clinic. We had students verbalize what they learned for the day, kind of a lessons for the day, if you will. They developed objectives for their next session. We targeted objectives for each student individually, and some of them were inclusive to all the students. We made connections between a patient one student was seeing to another. We had the students voice personalized objectives prior to seeing first patient of the day. What is your objective or goal for the day, one or more? We had students offer their own feedback, and then did they accomplish their personal objective? We have outside activities, some active learning type activities, evidence-based activities based on what the student has said they wanted to learn. And that's been, again, very helpful. I think the students are learning, more engaged in this process, at least in clinic they are. So my conclusions in going forward, certainly my approach to teaching is much different. I have a whole host of new tools in my toolbox. Classes become much more enjoyable. I'm pretty confident that the students are actually achieving class objectives now. And I'm learning to be an educator, and I realize that learning to be an educator is actually very valuable. I would like to change our own peer review process to include some of this reflective or appreciative inquiry. I think it was very helpful. I certainly wish I knew then what I know now. I think I would have been a better teacher starting out. It's taken me a while to get to this point, and I have yet to learn everything there is. I have a lot to go and a lot more to discover, but at least I have now started on this journey, and I definitely see a difference in my students and in my teaching, and I think it will definitely translate as these students move on into clinic. Here's a list of some resources for you in case you're interested, and I thank you very much for your time, and I'm ready to take any questions if you have any. Thanks so much.
Thank you for that excellent presentation, Kim, and for sharing your hard-earned lessons with us, as well as how you found ways to adapt to changes going on around you. We do have a number of questions from the audience that I would like to share with you. We have about 10 minutes for the Q&A section. First question. This seems to be a very time-consuming endeavor. What advice would you give to faculty who have been teaching in either the clinic or the classroom for many years in order to retool their content and possibly delivery? Specifically, they would like to know, where do they start and how time-consuming was this really?
Hi, that is a very fabulous question. So a couple of things, pieces of advice for you. I really think that, at least for me, the way to begin the process is self-reflection. The hardest thing about this is two things. One is to really look at the what and how of your teaching. How are you doing it? What are you doing? Do you know that you are successful? And the second problem is really to put aside some time. I think that is the most beneficial thing that you can do for yourself as an instructor in any form of, be it clinic or not, is to set aside some quiet time for yourself to really sit down and think about what it is that you want your students to learn. And that is really the place to start. You have to set aside some dedicated time, much like you would writing a research paper or any of the other things that we know that we do. But I think this is important enough that you block off some time for yourself. And that is actually what I did. I blocked every day. I blocked my calendar off, and I put, it may not be every day for you, but block some time off and dedicate yourself to it. So the question of how much time does this take, certainly that's going to be individual for each of us. The most time-consuming thing for me was going through the teaching fellowship. That was a more formalized, not a class, but a program that was very formal. We had responses that we had to type and send to our circle mates. We had to, do some readings. I mean, there was other times. So for me, I spent a couple of hours every week for that semester, a 15-week long semester. When I started to learn the language, I guess, of pedagogy, but that's what I'm calling it. When I started to learn what things meant, and I would go down the rabbit hole like you can with anything. You start reading about one thing and it takes you somewhere else, and you keep reading and you're looking up. It was very time consuming. When I got more facile with it, I think I spent probably 2 hours, 3 hours a week. But I retooled every lecture. Whether or not that's something that you have time to retool every your entire course, but certainly if you start with 1 or 2 lectures, 3 lectures, and you really try to focus on those and retool those, I think you'll find it's not quite so bad. Most of us, if you teach for a long time, you have the content from last year, you revamp it, and it's not as time consuming. But if you are really looking to change what you're doing, you have to set some time in your schedule, block it off, and really think about what it is that you're trying to accomplish. So that would be what I would advise if this is something that you're all looking to do for yourself.
Great, thank you. Next question, encouraging self-realization in our students in lieu of making educational deposits is certainly a better way. I just worry that I may not succeed in the engagement sufficiently to ensure that the educational goal will be met. How do you deal with this issue?
Oh, another boy, these are rough questions this afternoon. So here's what I think. The perfect learning environment would be self-realization, having the students come to the conclusions themselves. I don't think that in my course specifically that I have completely gotten to that point. It is not a completely you're on your own, we need you to come to all of this by yourselves. But what I do think how I think we can deal with this is to give them nuggets where they're actively engaging themselves, active learning, nuggets throughout, whether it's one lecture. So part of the challenge in my case was that I did not have a 3-hour block of time. My course is not a 3-hour continuous block of time. It is a 50-minute block of time twice a week, which makes it extremely difficult. So it was challenging to try and build in time for students to engage in activities. And it was not every single lecture. I don't want anybody to come away thinking that I've completely done away with the occasional oration, because that's not true. I think I still do that somewhat. I'm trying to limit it because I'm more self-aware. But if you can build in some areas or some activity within a lecture that allows the student self-discovery, and you do it often enough, you'll get really good at fitting in that kind of learning. I think you'll find that the students are engaged enough, and if you can assess the outcomes during the course, either with a Kahoot or some other type of assessment or a homework assignment or something, I think you'll find that there is actually a way to build this in without completely throwing out everything that you've been doing in the past. It's really a retool, revamp of the things that we know, the things that we teach, not a complete throw out the baby with the bathwater. So I hope that answered that question. Great question, by the way.
Great. And we have one last question we'll give right now. Did you find different approaches that worked best for fact-heavy topics versus clinical application type topics?
Yes, there's always going to be, again, part of this is dependent on the personality of the person teaching, right? I gravitated a lot to demonstrations and to, I'm a big prop person. And so I had all kinds of crazy props besides the eyeballs with the eyelashes stuck on it that I've been using, but props in class, that kind of thing. So if you have a fact-heavy course, there's a a huge resource. If you look in some of the resources that I gave you, there's a lot of resources with very creative ideas for things like fact-heavy classes. So I'm just going to give you one that I heard that I thought was phenomenal. So if you're teaching something, let's say it is anatomy, and you're teaching them blood flow through the retina, for instance, there you could devise sort of have the students come up with a game where they have to place pieces on a board. I know it sounds kind of cheesy and silly, but having the students physically create something where they have to place, you know, blood flow, where it goes, and, you know, capillaries and whatever it may be. And that is a way to deal with some of those fact-heavy courses. It's easier for sort of the props, clinical demonstrations, I think, for a student to visually see that they get hands-on in a laboratory setting. But it's a little different when you have, you know, pharmacology. You know, how are you going to teach them the, you know, inflammatory cycle? Well, maybe you devise a board game that the students have to develop, or things like that, creative things like that. So there is always a way. You just have to really get creative with what you do. And there's some fabulous examples out there. If you go to some of the resources I gave you, there is a ton of really fabulous ideas, very creative ideas.
Great. Well, I want to thank you again. We did receive some other questions and comments, so I'll make sure I forward those to you.
Great. Thank you very much for listening this afternoon, everyone. It's been a pleasure.
Great. Thanks, Kim. So moving on to our second presentation of the afternoon, Clinical Update, Pharmaceutical Developments by Dr. Blair Lonsberry. Dr. Lonsberry is a professor at Pacific University College of Optometry and enjoys giving continuing education courses on pharm-related topics. In addition, each year he teaches a systemic and ocular pharmacology course for bridging students at the University of Waterloo. As you will see, he is excellent at presenting complex material in a way that is relevant, understandable, and clinically applicable. For his OCEF presentation, he will cover an array of pharmaceutical agents, including little-known uses of older drugs, as well as newer drugs that are first in class. It is my pleasure to introduce Dr. Blair Lonsberry.
Hello, my name is Blair Lonsberry. I'm a professor at Pacific University in Oregon. I've been asked to do a clinical update looking at pharmaceutical developments, and I want to take a little bit of a different approach to this presentation as opposed to talking to you about new medications that are potentially going to be coming out, ones that are actually out and being used that you may not know about. If you happen to have any questions or any comments towards the end, please feel free to send me an email at blonsberry@pacificu.edu. So my email is there at the bottom. Please feel free to reach out. I want to talk to you about a case first. This was a case that Dr. Tammy Thon, a good friend of mine from Georgia, presented at Academy a couple years ago. We did a presentation together looking at the literature and seeing how that literature relates to how we practice. And this case was a 67-year-old female patient who had just had an eye exam done 3 days ago, but now is coming in reporting that she's developed, since that time period, headaches, vision loss for the past 2 days. Ocular history is unremarkable, so is medical history. But looking at visual fields, you can see that there's a significant visual field defect. The patient's developed a right hemianopsia. So again, thinking neurologically, right hemianopsia, we're thinking for something left side of the brain. MRI that was done can show where the aerial is pointing here that there was an ischemic event that happened on the left side of the brain. So thinking about this, patient's presenting 3 days after this visual field loss, the headaches, is there anything that we can do? So what would you recommend for this patient? Is there anything else that can be done that potentially helps the patient's not only neurological side effects to this, but also potentially the visual stuff? And interesting enough, minocycline is an option for this patient. And you're going, minocycline, why is an antibiotic being given to a patient who's had an ischemic stroke? And we know that minocycline, actually all the tetracyclines have very powerful anti-inflammatory properties to them. However, tetracycline and doxycycline don't actually cross the blood-brain barrier, where minocycline does, which is why minocycline is not the favorite for people to use, because they have much more neurological side effects to it. If they take it for other infections, they can develop vertigo, vestibular issues, because it does cross the blood-brain barrier, where doxy doesn't. But because it has this very prominent anti-inflammatory properties, one of the things that does inhibit is what's called MMP9, or matrix metalloproteinase. And this is a very powerful inflammatory mediator. In addition to that, it's also a proteolytic enzyme that breaks down tissue. It's found in patients who've had ischemic strokes that MMP9 levels are increased, which disrupts that blood-brain barrier, and it's also linked to poor functional recovery in patients. So minocycline can help reduce those levels in patients who've had a stroke. Also plays that anti-inflammatory role. Again, inflammation is going to be crucial in recovery for patients who've had a stroke. Results in a reduction in microglial activation. Microglial activation is believed to play a central role in neuroinflammation, also in progression of ischemic tissue damage. Results in increase in nitric oxide production. Nitric oxide is a very potent neuroprotective molecule. Basically, it's a free radical scavenger, helping to prevent tissue from further resulting in damage. It also results in inhibition of apoptic cell death. So apoptosis may contribute to significant significant proportion of neuron death following ischemic brain ischemia. So minocycline has very potent anti-inflammatory and properties that can result in improvement in neurological function in patients. So what does the literature say about this? Well, there's been several studies that have come out. This one actually dates back to 2007. So this has been around for a while. In this study, patients who reported to an emergency room within 24 hours of an ischemic stroke, not hemorrhagic, but ischemic strokes, were brought into this study. So there's 152 people that were part into this study. They were given minocycline 200 milligrams once a day for 5 days. So we think about it, what's really the side effect of giving minocycline to a patient for 5 days? Well, really nothing. It results in potentially increase in GI upset for 5 days, some sun sensitivity, but really there's not a significant side effect of giving a patient minocycline for 5 days. It's not certainly going to interrupt with any of their other care that they're getting, and doesn't have potential neurological benefits to a patient. So the patients that were given this, they were put on what's called the NIH stroke scale. That's the scale that's off to the right. And it looks at multiple different things in the patient. So it looks at, do they have motor issues, arm, leg, visual field issues, facial palsies. As you can see, there's a whole list of them, and the score adds up. So every check mark that they get an additional point to this. 0 to 1 looks like it's completely or nearly completely improvement. 2 to 7 is considered mild. 8 to 14 moderate. Greater than 15 is considered severe. In this study, there's actually 3 different studies here, but we're looking at the top one right now. The patients that were incorporated into this study started in the minocycline group, 7.5, in the control group, 7.6. So if we go back, that's basically between mild and moderate. Patients were given the 200 milligrams of minocycline for 5 days. We can see that at day 7, there's actually a significant improvement in patients where the control group actually got worse. At 90 days, patients are almost completely resolved at this point in the minocycline group, and there's been some subtle improvement in the control group, but not significantly. There's been 2 other studies that looked at this as well. So this next one, also decreasing scores shows better improvement. So the minocycline group starts at 2.8. At 90 days, they're at 0.9 versus the control group, which didn't change at all. This bottom study had actually increasing numbers, was an improvement. So they started at 70 in the minocycline group, 64 in the control group. At the end of the 90 days, they're at about 95 for the minocycline group versus 77 for the control group. So I think these studies show that there is the potential for neurological improvement in patients who are taking minocycline. I just read a review, a 2019 review that looked at kind of all the literature and said there's definitely a benefit to patients who've had a stroke to getting minocycline. It shows definite neurological protection stuff, but it really was looking at between about 24 to 48 hours of patients having a stroke that this shows improvement. There's just not a ton of research that's been done past that time period. However, what does this mean to us visually? Well, there was a study that, a case study that came out by Dr. Tomczyk and Dr. Skulski in 2011, where they had a patient who came in who saw a news report on television about the potential improvement in patients who've had a stroke by using minocycline. So this patient knew that they had a significant visual field defect. You can see that there's a significant left hemianopsia going on with this patient. This is 3 weeks out post that stroke, and the 2 doctors started this patient on minocycline 100 milligrams twice a day for 5 days. And we can see that shortly after starting that, there was a significant improvement in that visual field. So the top visual field shows significant improvement in that hemianopsia. And a year later, that was maintained, if not actually better than that. So I think there is a role for us to play with potentially patients who've had a stroke in their visual fields. I can't answer the question about how long post-stroke is there a benefit to it, but I think also the flip side to it is the the side effects of doing minocycline for 5 days is pretty limited. There's just not a ton of side effects the patients are going to have. So I do think it's something we need to think about for patients, potentially resulting in not only improvement in their neurological signs, but also in their visual fields. The next thing I want to talk to you about is a compound called oxybate or synindramine. This is the first approved medication for the treatment of neurotrophic ulcers. Neurotrophic ulcers are a relatively rare finding in patients, but when it happens, it tends to be very visually devastating for them. So potentially after patients who've had a herpes zoster infection, herpes simplex infection, potentially patients who have had diabetes, develop a fifth nerve palsy, develop a neurotrophic ulcer, and neurotrophic keratitis. This molecule has been found to improve the healing of the cornea, also the improvement in the nerve in the cornea, improvement in health as well. The efficacy and safety of this molecule was really found in Europe. There was 2 big randomized studies that looked at this one. This molecule, there's compounds given every 2 hours, so 6 times a day, every 2 hours for 8 weeks. In the 2 studies, 70% of patients who received the treatment had complete corneal resolution after that 8-week time period versus 28% of the controls who really didn't show any improvement at all. So I think that the studies show that there's a significant potential for improvement by treating patients with this compound. My personal experience for this one is I do practice in Alaska. When I get a break from the school, I go up to a private practice up in Alaska in Anchorage, and I work there. So I go up there every about 3 months or so. And I was up there this past summer, and one of the doctors there, Dr. Liz Lane, asked me to consult with her on this patient that who's had a neurotrophic ulcer for just over a month now. And she's tried amniotic membrane, she's tried a band of contact lens, heavy lubrication, and hasn't been seen to be much improvement in this neurotrophic ulcer. So this patient's a 60-year-old male patient, presented firstly because the fact of some irritation, slight decrease in vision, watery, photophobia, that type of stuff. When she examined him, diagnosed him with a neurotrophic ulcer, started him on an ofloxacin, so an antibiotic drop, bandaged contact lens with heavy lubrication. Patient came back a few days later, really not feeling much better, maybe slight improvement, but Dr. Lane decided to put on an ambiodisc, so an amniotic membrane. Remember, this is the dehydrated form of the amniotic membrane where it has to be rehydrated, put on the cornea, then the bandaged contact lens goes over top of that. And had the patient come back in a week, and there was slight improvement. So this is the slight improvement, these pictures here to the right, showing that it's still there, but there's some improvement over the previous one. So at that point, ambiodisc was taken off. The patient was put back on a contact lens. The patient came back after the next day saying they're complaining about contact lens irritation. So removed the contact lens, put the patient on antibiotic and also on Cequa. Cequa, if you don't happen to know, this is from Sun Pharmaceuticals, and it is cyclosporin, but it's at 0.09% versus Restasis, which is 0.05%. And Sun has come up with a unique delivery mechanism for the cyclosporin molecule. Cyclosporin happens to be actually hydrophobic. So when you put it in the tears, it tends to be rejected by the tears. So they developed this nanomicellular formulation where the cyclosporin is in the center of that little ball, and that is a hydrophilic molecule that ends up getting into the cornea, releases the cyclosporin at that point. So there's a significant improvement in delivery by about 3 times versus what you're getting from normal Restasis. Same molecule, same cyclosporin, just a higher concentration and different delivery mechanism. So the patient was put on Cequa. A request was, she consulted with me and said, is there anything else I can do for this patient? I'm putting him on Cequa, is there anything else I can do? And I said, well, why not try oxybate? And she kind of looked at me a little bit strange going, I have no idea what you're talking about. And I said, well, oxybate's the first medication that's ever been approved for neurotrophic ulcers in patients. But the downside is, can we get it for the patient and how much is it going to cost? So she put a request in for oxybate. Took about a month in order to get that approval for it. She began the oxybate. It is 1 drop basically every 2 hours for 6 times a day, and the treatment period's for 8 weeks. So after a week's treatment, you can see that the patient's, this is 9:15 up here on the right, showing that there's still some resolution, there's still some lesion there, but after 2 weeks of treatment, it's almost completely gone at this point. She continued it for the full 8 weeks, and all what's left is a bit of subtle scar that's there. So after 2 weeks of this medication, pretty much resolved the neurotrophic ulcer that was there. Downside to it, as I mentioned, is the cost. There's the EOB for this one, so $25,000 for this medication. obviously not a cheap medication. Thankfully, the insurance paid for the majority of this medication. Really, the downside to this medication is the cost to it. It certainly works, but it's the cost in getting it for your patients. I've talked to Paul Karpecki, who's worked with this medication more than I have, and said that a lot of times you're gonna have to go through the insurance company, have it rejected by the insurance company, then you can approach the actual company itself, and they can potentially get a patient on a patient assistance program for getting the medication. The next one I want to talk to you is called UPNEEQ. This one you might not know about. This one is actually designed for patients who have blepharoptosis. This is an eye drop, and it's the first in class in this medication. We know that with blepharoptosis, as patients get older, they potentially have this development of ptosis. Most times the resolution of this or correction of this is a surgical intervention, so they have to have a blepharoptosis surgery that's done. Big concern for patients is not only the cosmetic appearance to it, but also the fact that it's also covering the superior part of the visual field. So as it gets closer to the pupil, they have a significant reduction in their visual field, which is why we tend to do with lids taped and not taped in order to show improvement if they end up having blepharoptosis surgery. Well, this medication is given once a day, and there was 2 big trials that were looked at. So it's once a day for 42 days, so about 6 weeks worth of treatment. In this case, what we're looking at is actually improvement in visual field. So this is the Leicester peripheral field test, looking primarily at the upper 4 rows, which is what we're concerned about because that's coming from the lid droop, and showed that there was a significant improvement in patients getting this treatment once a day for 42 days, that there's a significant improvement in their visual field function. But patients are also going to be concerned about cosmesis as well. And you can see here, again, UPNEEQ given once a day for 42 days, shows there's a significant improvement in visual or the ptosis in these patients. So cosmetically also works very well for patients. You can see that after 2 hours, there's significant lifting of the lid. At 6 hours, it's being maintained and even potentially a bit more. They've seen improvements in patients within actually 5 to 10 minutes of putting the drops in, but kind of that peak activity is between 2 and 6 hours, and it lasts for the entire day. So this is potentially something that we can prescribe for patients as opposed to referring them for surgery. And a lot of patients are hesitant in surgery, particularly now with COVID and not people wanting to do elective surgeries, that this is certainly going to be a benefit for our patients to improve their not only cosmesis, but also improvement in their visual fields. Again, it's 1 drop per day in the affected eye. Adverse reactions were punctate keratitis. Be cautious with patients with cerebral coronary insufficiency and Sjogren's syndrome, and this can potentially induce an angle closure in patients who have narrow angles. Thyroid eye disease, Graves' ophthalmopathy. Patients who have Graves' disease have a greater chance of developing thyroid eye disease, resulting in proptosis, dry eye, potentially even loss of vision once you start getting compression of the optic nerve. So we have always been concerned about patients and developing thyroid eye disease. Traditional therapy has really been the use of corticosteroids systemically, or if it gets to the point where those are not successful, is then optic nerve decompression, which is obviously a huge surgical intervention for patients and doesn't necessarily always work. Orbital radiotherapy has also been used as adjunctive therapy in patients during active disease, but there's now actually approved medication for the treatment of thyroid eye disease. This was given kind of a priority approval. It's developed by Horizon Therapeutics. This is an IV treatment, so it's 8 doses. It's 1 dose IV treatment infusion every 3 weeks for a total of 8 doses. But look at the cost. It's $15,000 per dose. So we're talking over $100,000 for the treatment in this case as well. So again, not cheap, but has shown significant improvement in patients with thyroid eye disease. The 2 big trials that came out showed that patients had a reduction in 2 millimeters of their proptosis in 71 and 83% of the patients versus the control group, where they only had a 20% or 10% reduction in that proptosis. The other part to it is patients often with thyroid eye disease have diplopia. It showed a 70% improvement in patients with their diplopia, and in 50% of those patients, there was complete resolution of their diplopia. So again, this is the first in class in this medication for the treatment of patients with thyroid eye disease, not going the route of steroids, which we know have lots of complications, or surgical decompression. Downside to this one is going to be the cost of the medication. Giant cell arteritis, one that we're familiar with, also referred to as temporal arteritis. Patients typically tend to be older in this group who get this condition. So definitely over 60, generally in that 70 to 75 age range. Women more than men, 2 to 1. Caucasians likely more affected in this case. Patients do have A strong link to polymyalgia rheumatica with this condition as well. Patients are going to present with a temporal arteritis, the jaw claudication, the scalp tenderness will tend to be systemically sick, don't feel well, loss of vision, APD, all the rest of it. Traditional therapies been IV steroids for these patients, high dose IV methylpred, in order to not necessarily improve vision in that eye, though there's some hope that the vision in that eye will improve, but mainly for preventing from transferring over to the other eye and patients losing vision in that other eye. Remember, this is a clinical diagnosis. Patients come in with the symptoms that they should actually be sent off for treatment even before confirmatory testing has been proved to confirm it. We tend to run ESRs and C-reactive proteins to want to do a biopsy if we can, but because the chance for transference is so quick, the patients will actually be treated prior to getting confirmatory diagnosis. There is actually a treatment, it's been out since 2017, but when I talk to doctors about this, very few people seem to know about this treatment. This is a treatment that's actually been used for patients with rheumatoid arthritis. It is an injection for patients. This is called Actemra. It is designed, it's a first in treatment for this form of vasculitis. So it's the first FDA approved medication to treat vasculitis. And compared to the typical IV steroids that's used, showed a significant improvement in patients who've done this treatment in addition to the steroids versus just doing the steroids alone. So something I think that certainly needs to be thought of, particularly when, depending where area you live in. I would suspect ophthalmology knows about this, but I don't know if the person's being sent to an emergency room, whether or not the emergency room physicians know about this. So something I think you need to keep in mind is something that I would certainly advocate for your patients. If they think that they have been diagnosed with a giant cell arteritis or temporal arteritis, that this is certainly the recommended treatment for them. Next thing I want to talk to you about is called Dextenza. What's a dexamethasone intracannulicular plug? So an implant, much like a collagen plug that you would put in. This medication, dexamethasone, dissolves over a 30-day time period. Was approved in December of 2018, and you may have seen this being used for patients post-op cataract, which is what it was approved for. It was approved for ocular pain after surgery, in particular after cataract surgery. How it works, again, it works like a collagen plug that's inserted into the lower punctum. It swells at that point, lodges itself in there, and slowly releases the dexamethasone over a 30-day time period. Probably not something we tend to be probably using because there are not many cases that we would want to be doing this, be doing after surgery. But I saw this article. It's actually by a good friend of mine who's an ophthalmologist in Fargo, North Dakota, corneal surgeon. We've actually done some lecturing together. And I read this article of his, and I thought this was really pretty fascinating. Something that I've now started to talk to our refractive surgeons about whether or not they're doing this, is that he did this study comparing comfort and just patient satisfaction of doing a topical steroid drop post-op refractive surgery versus being implanted with this dexamethasone implant. And patients 80 to 90% way favored the dexamethasone implant. They didn't feel like they had to take the drops. They showed definite improvement in not only corneal staining, but comfort, et cetera. And it was just a lot easier for them to do than taking drops. In particular, in this time period when we're going through, again, through COVID and trying to reduce the follow-up appointments we have in patients, that this is definitely what I think that we're going to be moving towards. So something that you might want to talk to your refractive surgeons about and be part of this protocol. Make sure that you understand that this may be happening in your refractive surgery patients, not only your cataract surgery patients. The last thing I want to talk to you about is capillary hemangiomas. We know this typically happens in kids at birth or shortly after birth. This tends to be that collection of blood vessels that are there. So if you press on it, capillary hemangioma tends to blanch with that. Majority of kids will tend to get this resolution on their own. However, if there's a significant amount of capillary hemangioma that's pressing on the lid, which can then press on the cornea, which they develop weird forms of astigmatism, they can develop meridian and amblyopic components with it as well. We have to be very concerned about not only the cosmesis to it, but also potential visual function as well. 75% of them regress to some extent by 7 years on their own. However, treatment's been either injecting with Kenalog or triamcinolone or doing potentially laser treatments. Well, we know that there's other treatments for these, and that's been oral propranolol. Oral propranolol has been shown to be really beneficial in reducing these capillary hemangiomas. The beta blockers are thought to work by 4 different mechanisms. They are thought to result in vasoconstriction of the capillary hemangioma. They inhibit the angiogenesis or the proliferation of the blood vessels in that area. There's induction of apoptosis, so death of those cells that are there, and also recruitment of endothelial progenitor cells to help reduce the development of that capillary hemangioma. Well, who wants to put oral propranolol in a 6-month-old? Well, not many people, I don't think. Well, topicals have actually shown to be a benefit as well. So in this case, use of topical timolol 0.25 or 0.5%, the gel forming solution, so results in a gel when it comes out of the bottle, has been shown to be beneficial for patients. In this case, showing the picture here to the right, this is a young child that had a capillary hemangioma on their lid. This was timolol 0.5 given twice a day for about 3.5 to 4 months and showed complete resolution of that as well. So something I think that you need to be familiar with, that patients might be coming in, either read this or heard about this, and might be asked to be prescribed a topical beta blocker for the treatment of capillary hemangiomas. I think I'm out of time. I really do appreciate you being with me. If you have any questions, please email me at blonsberry@pacificu.edu. I'd be happy to answer any questions, and thank you for your time.
Great, thank you, Blair. That was a fascinating presentation, and I trust we all learned a clinical pearl or two from you today. I actually saw Dr. Waldorf taking copious notes as you spoke, so that's a good sign. We have about 5-10 minutes for questions. We did get a couple questions for you. So let me just pull those up. Okay, first question. Regarding Unique, this is an old drug with significant potential for rebound hyperemia. One that in the old over-the-counter allergy relief formulation would not have been recommended to patients. Now it is a very expensive drug. What are your feelings on that?
Yeah, so I think we've always kind of recommended to patients that they're not taking these vasoconstrictors for long periods of time because of the potential for rebound hyperemia. I don't know the concentration offhand of the over-the-counter medications. At this one, it was really designed to look at patients in increasing, obviously, their ptosis for their blepharoptosis. And for me, I think that that's what you're going to be looking at in this case is, are you sending a patient off for surgical referral versus the potential for getting some redness? I'd have to go back and look at the studies and see what the side effect profile for it was. My understanding was that redness wasn't a significant detractor from patients using it. I think that the cosmetic improvement was much kind of outweighing the fact that they were potentially getting some rebound hyperemia with it. I do understand that we're talking now of potentially a much more expensive medication, but I don't think that they were seeing that increase in or the reduction in ptosis in using the over-the-counter products, which they're finding in this product. So I assume that the concentration is probably different.
Okay, great. Second question, Dextenza, is there a significant IOP elevation?
There has not been at this point in time. Certainly that would be a concern. Remember with Dextenza, it's basically out of the system in 30 days, right? So, and it's kind of a tapered release over time. So they're getting a bit of a higher dose at the beginning and tapered as time goes through. Dexamethasone certainly has a greater chance to result in IOP increases in patients, but I don't think they've seen it at this point. Again, I'd have to go back and look at the studies for what it was approved for kind of post-op cataract and so on. But I think you have to remember that this is being used for a very short period of time, that we're using it for 30 days. And from what I can tell, that there hasn't been a significant increase in IOP from what the studies I've seen.
Great, thank you. And lastly, I know there are a couple of new ocular medications out there that you wanted to put into the presentation, but couldn't because of time constraints. We do have a couple more minutes. So is there anything else that you would like to share with the group at this time?
Yeah, so there's been a couple products that have been recently well, one for sure that's been approved recently from Kala Pharmaceuticals, and it's called, I don't know for sure if I'm pronouncing it right, but Eysuvis, so EYSUVIS. And this is actually low-dose loteprednol, which has been indicated for the treatment of dry eye. So it's used for effectively about 2 weeks to try to get some dry eye symptoms under control. So they just recently approved that medication, which should now be available for the treatment for patients. Again, it's indicated for a 2-week time period. I think it's 4 times a day dosing on that one. Again, to try to get patients, I think, dry eye kind of under control. It's not necessarily approved for permanent use or constant use, but it has been approved for at least 2 weeks treatment for patients with dry eye. There's also been a couple drugs that have been put into kind of further FDA trials as well. One of them is, sorry, I'm just pulling it up here. It's for pediatric vernal keratoconjunctivitis. This is actually a cyclosporin preparations coming from Santen. they have now just started recruiting patients for it for trials. So something that they're looking at to potentially get out in 2021. So something that you might be looking for. And another one is the continued trials for presbyopia. So Alcon has a product that they're looking at, which is a pilocarpine, I think 1.25% that they're looking at continued clinical trials for presbyopia. So again, still working on that. I don't know timeline for when they're expecting to potentially have that approved, but that's still in the works as well. And I thought I had one more. Oh, and I was just going to tell you about UPNEEQ as well. If you are looking at potentially trying to prescribe it, they have one pharmacy that they go through. It's called RVL. So it's not something that you can actually write a prescription for your patients to take to the pharmacy. It has to go through RVL pharmacy. And you can potentially, if you have an EMR system that you have something like SureScripts, you can potentially find it through there. If not, you're going to have to fax that prescription over to RVL. Then RVL will actually contact the patient for their credit card information and so on. But just as kind of a side note for UPNEEQ is that it's not something that you can actually write a prescription for your patients to take to the pharmacy. It has to go through RVL pharmacies.
Great. Well, once again, I'd like to thank you for your contributions. That was fantastic.
Thank you.
So we're now going to do we're going to do a 10-minute break so folks can stretch their legs and refill their coffees and such. Right now it is 2:56, so the presentations will commence at 3:06. Thank you.
Welcome back, everybody. This couple of housekeeping items I'd like to share with you. This lecture, all of the lectures, the presentations are being recorded, and in about a week or so, the links to the lectures will be emailed to the your liaisons at each of your universities. So you can look for that. I know some people have had some technical difficulty. Secondly, I'd just like to remind everyone that we will continue to be accepting questions, which the speakers will be addressing at the conclusion of their presentation. You can submit the questions anytime during the presentation by writing them in the box under questions sections of the control panel. So now moving on to our third session of the day. I think at one time or another, most of us have kind of thought, what is wrong with these kids as we precept different generations in our clinics. Our next presentation, Effective Teaching and Communication Strategies Across Generational Divides by Dr. Elise Shaglazian and Dr. Jimeni Patel, will bring you up to speed on some differences between generations and how to bridge generational gaps to become more effective clinical educators. I'll now hand the presentation over to Dr. Shaglazian and Dr. Patel.
Hello everyone and good afternoon. Thank you for joining us in the ASCO Online Clinical Educators Forum. My name is Jimeni Patel and Dr. Shaglazian and I are here today to discuss effective teaching and communication strategies across the generational divides. I'd like to thank ASCO and all those involved in organizing the Online Clinical Educators Forum and for inviting us here today. A little bit about myself. I'm an ICO grad and completed my residency in ocular disease and primary care. I'm currently an assistant professor, the externship education coordinator, and the lab coordinator for the Ocular Disease 2 sequence. My co-presenter and mentor is Dr. Elise Shaglazian. She's a full-time associate professor at the Illinois College of Optometry and supervises clinical care at the Illinois Eye Institute. She currently serves as the assistant dean for community-based education and international programs at the college, and she lectures on topics of refractive surgery and anterior segment disease. Neither Dr. Shaglazian nor I have any financial disclosures to report. Today's lecture objectives include understanding the different generations, traditionalist baby boomers, Generation X, Y, and Z, and we will also discuss the roles of clinical educators, student clinicians, and the college administration as it pertains to effective communication and teaching styles. This photo is a good depiction of what we see day to day in various settings. Lectures, labs, restaurants, or even while crossing busy roads. This trend is across all generations, however, is becoming the new norm in younger generations. Folks are always connected, whether it's through text, calls, video calls, Facebook, Instagram, Twitter, Snapchat, and the list goes on. To understand each individual generation, we must understand the timeline of generations. The first generation starts with traditionalists. Then we have baby boomers. This is the group that Dr. Shagwazian belongs to. That's followed by Generation X. Then Generation Y, which is also known as millennials. This is the group that I belong to. And then lastly, we have Generation Z. You can see Dr. Shagwazian's children are a part of this group, and this is the current age of students attending optometry school. Let's look closer at each generation. Traditionalists are those born prior to 1945. The youngest of their generation are currently 75 years old. This group values hard work and expects work to be done in the office. They value authority and a top-down management approach. They live by a motto, make do or do without. Then we have baby boomers. This group was born between 1946 and 1964, making their current age between 56 and 74. They peaked at 79 million in 1999. Their individualistic and optimistic personality is secondary to the post-World War II optimism. They grew up under the influence of televisions, radios, magazines, and newspapers, but have adopted more technology to stay in touch. So much so that 90% of baby boomers have a Facebook account. There was a huge emphasis on science and education while this group was growing up. This cohort wants to be respected and appreciated. Generation X was born between 1965 and 1980, and their current age is 40 to 55 years old. This group is smaller than its preceding baby boomer generation and its succeeding millennial generation. They are thought to be more pragmatic, skeptical, and disengaged compared to other generations. This group was influenced by media and television channels such as MTV. While they respect authority and will work as hard as required from them, they prioritize a work-life balance. This group is often lost between two very large generations. Now onto the two generations that make up a majority of our student body, millennials and Generation Z. I think we can all relate to this cartoon, either being in one of their shoes or sympathizing for them. While the onus used to fall on students, we now see a lot of parents becoming more combative with teachers as they believe that their children are never to blame. This shift was first seen with Generation Y, or millennials. This group was born between 1980 and 1994. However, this number may vary by 1 to 2 years, pending the source. They were influenced by violent events such as 9/11, the wars in Iraq and Afghanistan, or school shootings. They also witnessed a rise in technology and the internet, making them comfortable with mobile devices and computers. They have multiple social media accounts. They tend to have helicopter parents who are quite involved in their lives and have a sense of entitlement. Millennials also wish for a work-life balance and are entering the workforce with a high amount of student debt. Given their comfort with technology, this group prefers web-based instructions when learning new material. They wish to collaborate with their peers over sitting in lectures. They look for accessible and approachable professors who prioritize teaching relevant material. Then we have Generation Z. This group was born between 1995 to 2010 and are heavily influenced by advancement in technology. They have access to more information than any other generation at their age. They grew up with iPhones. They are also shaped by the same violences that millennials experience, as these issues are ongoing, and they watch their parents deal with the financial hardships of 2 recessions. They lived through social injustices, witnessed legalization of same-sex marriages, the BLM movement, as well as controversial topics such as immigration, religious freedoms, transgender rights, and women's rights. Northeastern University's Innovation Survey found that Gen Z prefer to have hands-on learning that can be applied to real-life scenarios. Generation Z are observers. They prefer to watch tasks be completed themselves by a teacher prior to them trying it out for the first time. A good example of this is YouTube. They prefer YouTube videos over instruction manuals or recipes. Thus, creating videos is a great tool when teaching courses or optometric skills for this group. They prefer multiple educational tools, such as reading articles or books, completing online assignments, or watching instructional videos. They prefer to learn at their own pace and understand concepts themselves prior to sharing it with their peers. Optometry, like most medical fields, is rooted in traditions and customs that boomers and Gen Xers abide by and expect from our students. But they're not going along with that, and this can lead to conflict and stressors. These students want to hear more praise. They demand more attention. They dislike learning via traditional methods. They prefer structure, boundaries, and rules. They want a clear list of expectations. And they desire open and frequent communication with authority. Again, they want a professor who is accessible and available. Generation Z Stories Projects was a qualitative study of more than 1,300 students from 50 institutions. The study found that Gen Z had a limited involvement in volunteer programs compared to millennials and prioritized lasting societal impacts over short-term volunteering. The example that they gave in this study was they would rather solve worldwide hunger issues than to work at a food shelter themselves. Gen Z craves understanding passion and the underlying values of a company that they choose to work for over viable career options. They want to understand who they work for and what that company stands for. The term gig economy was defined by Alka Topi and Andrew Hogan as an economy made of freelance workers rather than long-term contracts. They prioritize happiness and enjoyment of their career over earning money. When we think about these younger generations, a few terms come to mind. The first one being narcissism. These two generations agree to a certain extent with the statements on this slide. If I ruled the world, it would be a better place. I'm a special person. I can live my life any way that I want to. And the last one is, I am an important person. A study completed showed that 12% of teens agreed with that statement in the 1950s, while in the 1990s, 80% of teens would agree. There's abundant evidence to support this narcissistic culture emphasizing self-worth. The second term is entitlement, a relatively stable belief that one should receive desirable treatment with little consideration of actual deservingness. The next slide outlines a great example of this. Dear Dr. Huang, before you put in the final grades for our Tuesday-Thursday class at 6 p.m., I would like you to consider how hard I tried and how hard I studied, but could not understand the material. I miraculously made it out of my first 2 chemistry classes, and first time I took your class for Chem 1. I withdrew simply because I did not understand chemistry whatsoever. It's my downfall, and for me to repeat it would be the same outcome. I'm not asking you to give me something I am not deserving of, but please help me in any way that you can. I cannot bear retaking chemistry again, Dr. Huang, so I'm asking you, is there anything that can be done so I would not have to? This was an email sent to a chemistry professor. The student earned a poor grade, but really believes that they deserve to be marked up because of how hard they tried. The last thing I want to discuss is technology and mental health, specifically the negative side of technology. Turner described 3 areas in his article discussing the pitfalls of technology. The first topic is cyberbullying. Computer screens and cell phones are safe havens that bullies can hide behind. They no longer see the physical consequences of their malicious behavior, and they don't feel remorse for the things that they say. The second topic was instant gratification. These younger generations live in a wired environment and near their devices at all times. This allows them to keep up with social media immediately, thus feeling instant gratification, or they can feel hurt, utterly unimportant, or dismayed by the lack of attention that their content receives. Lastly, the term absent presence, which means that people may be physically in one place while their social attention and communication focus is elsewhere, was developed by Rainey and Wellman in 2012. I think we've all witnessed this in a classroom setting where students believe that they can multitask, but are doing a disservice to themselves by not providing their professors with the attention that they deserve. So how does this affect mental health? The stats on the slide show a huge increase in depression, anxiety, psychological distress, and suicide. I want to point out the study that was done by the National Survey on Drug Use and Health that showed that from 2005 to 2017, there was a 63% increase in major depression, a 71% increase in psychological distress, and a 49% increase in suicidal thoughts. What does this mean for us? There is a shift in universities nationwide with the expansion of counseling services and modifying their curriculum and grading system in attempts to reduce anxiety and depression. There is an accelerating rate of increase in depression, anxiety, and suicide, and there must be support systems set up for our students. That wraps up my summaries of each generation and how this impacts educators. Thank you for listening, and now I'll turn it over to Dr. Shaglazian.
Thank you, Dr. Patel. Let me publicly thank you for being a tech-savvy millennial willing to always help this tech challenge boomer. That was a great setup for the next part of our presentation, which will focus on working with millennials and Gen Z students in the clinical setting, how to turn those encounters into positive and productive experiences for everyone. I will break this down into 3 areas: the roles of the clinical educator or attending doctor, the role of the student clinician, and lastly, the role of the college or university administration in supporting everyone involved in the educational experience. Since we are all clinical educators, I thought it would be prudent to revisit the definition of the word preceptorship. Optometry students primarily spend the first part of their education in the classroom and gradually transition into increasing amounts of hands-on patient care experience. It's our job to be their guide on that journey and support them to bring that didactic knowledge and laboratory experience forward to the clinic setting. As we know, that journey can be fraught with both reward and frustration for all, and Dr. Patel has nicely laid out how the generational divide may account for some of that. You've also likely noticed, to one extent or another, that students need and expect more support than ever at all hours. What we do is exciting and rewarding, but also challenging, so it's important to remember your why. Why did we become optometric educators in the first place, and why do we continue? Simon Sinek wrote a book several years ago that many of you are likely familiar with, entitled Start With Why. He discusses how people are inspired by a sense of purpose, the why, and that should come first, before the how and the what. As optometrists, we have many different practice settings to choose from. So why education? Is it to be challenged by our colleagues, our students, and our residents, to stay up to date in the profession, give back to your alma mater, or pay it forward by mentoring your younger colleagues and guiding future optometrists? Our primary job is obvious. It's to teach students how to be excellent, independent clinicians. It's how we go about doing that job that may not always be obvious and often goes beyond the exam room. Students pay attention to what you do and say, and intentional or not, whether you want to be or not, you are a role model. They watch you display not only your clinical acumen, but your communication skills with the patient, how to establish rapport with them, and provide the best patient education. But of course, we also need to observe their skills and their attitudes and behavior. But you can also teach away from clinic, holding case discussions, journal clubs, or providing assignments on a topic that you deduce needs further understanding. How many times have you heard a student say to you, they didn't really know what you wanted, and you thought, did I really need to tell them that? They should just know. My point is, you can't make assumptions. Students like and need to know your expectations up front. In other words, they expect your expectations. I have an online clinic page that I use to communicate with my students each quarter. Though like you, lately a lot of my communication has been through Microsoft Teams. I post my do's and don'ts, my clinical expectations, a week before the start of the quarter, and clearly state that I expect that they will be read and the student should come prepared to work with me on the first day. In fact, I insert a trivia question in the middle of them, not at the end of the page, so I ask it on the first day. And in case you're interested, this quarter the question was, what was your favorite book to movie adaptation? And let me tell you, there are a lot of Harry Potter fans out there. When I first created my do's and don'ts years ago, they fit onto one side of a single piece of paper. Over time, it's expanded to both sides of 2 pieces of paper to include items I previously believed would be just common sense, such as showing up on time, dressing professionally, and being clean. how to conduct a thorough and problem-focused case history for diabetics, hypertensives, and glaucoma patients. Being polite and professional, what tests should be done when, and how to document findings appropriately. I struggled for a long time as a boomer to see how and why this was my responsibility. Shouldn't they work it out if they didn't understand something? That's what I did when I was in school. Does that sound familiar? Ultimately, I realized the answer was that I am unable to change the mindset and behaviors of these new generations, and if I wanted to remain effective and fulfilled in my job, that I would have to modify my expectations and behaviors to some extent. And while I'm sure there is more I can still do, I'm cognizant of what millennials and Gen Zs respond to and what they don't. Now on to my don'ts. Yes, it bothers me when the students chew gum and when they pull out their cell phone in the exam room if it's not to look up a medication or with my permission. And we've all had that moment where we cringe when they say something in front of the patient that may or not be accurate and is certainly alarming to the patient. One of the tools that some of our faculty members have found helpful to use in clinic is this grid that students use for pre-charting, so they have familiarity with the scheduled patients for the particular session. This is an example of one that's used in one of our retina sessions. I personally find that a prepared student is more comfortable, less anxious, and more confident. All of us evaluate students in various categories such as knowledge base, clinical skills, data analysis and management, communication and professionalism, whether it be per patient, per session, per day, per quarter, both in verbal and written form, including using something like MetaTrack. The expectations do and should change dependent upon the level of the student's experience, and those goals and expectations should be clearly laid out and made available to both the student and the faculty members. Students desire communication in person, by email, and virtually. As Dr. Patel mentioned, they're constantly tuned into their devices and media, which may explain the emails they send at all hours. It's important to provide them with timely and constructive feedback, both praise and criticism. What studies have shown is that when we neglect to address issues in a timely manner, it's interpreted by the student as a success. And that feedback can't be vague, like, good job today, which I know is something I'm guilty of doing. The feedback needs to be specific and related to their performance with that particular encounter. So knowing all this, how am I doing as a clinical educator? Well, here's a sampling of my third-year primary care clinic evaluations, and I bolded some of the superlatives. Expectations were made clear, valuable feedback, verbal and written feedback. I'm professional, friendly, fun, and amazing educator. I'm feeling pretty good about myself right now. But then, apparently I still have more work to do. I made someone feel less than, I was rude, I should be more approachable, and I'm condescending. I asked Dr. Patel to share her evaluations as well to see if there was a disparity possibly based on how the students perceive working with a baby boomer versus a millennial, one of their own. But you can see that we each get both praise and criticism. Notable to me is the desire here to be recognized when they do something well. They want to be noticed. Here's a word cloud of adjectives students frequently use in their evaluations of preceptors they give high marks to. Those teachers are passionate and welcoming and friendly, respectful, understanding, provide feedback, they're approachable. On the other hand, this is a word cloud of what they consider to be negative attributes. Preceptors they find to be intimidating, belittling, bullying, unorganized, condescending. They don't provide expectations. So moving on to the role of the student clinician. Just as it's your primary role to teach, theirs is to learn. They need to actively prepare, be engaged and participate, and do so in a professional and respectful manner. As I discussed earlier in my do's and don'ts, I asked the students to schedule a short meeting with me to discuss their strengths, weaknesses, and goals for the quarter. What if your student is struggling? If a student is identified as being deficient in some aspect of clinical performance, the key is early intervention to enroll them in some sort of enhancement process. The student has to be invested in the process of determining where the issues lie and working together to improve them. Since we instituted a formal enhancement program at ICO, we have found that working on just one or two of the major issues often improve others as well. As Dr. Patel mentioned, millennials and Gen Z suffer from high levels of mental illness such as anxiety, which is often undiagnosed or untreated. Having on-campus mental health services becoming necessary and expected by today's generation of students. Finally, the role of the college or university to support the students and faculty to reach their potential and do so in ways to promote everyone's satisfaction and mental well-being. As clinical educators, we know what we want to accomplish and somewhat how to get there. Many of us learned and now teach in a traditional model. The model can still work well for many students, but it doesn't truly evaluate the student's knowledge or their analytical abilities. In this model, the educator tends to talk over the student and be more directive in the patient care, which is not an optimal method to discern the student's strengths and weaknesses and thus be able to provide worthwhile feedback. I'd like to talk next about the 1-minute preceptor model. In the 1-minute preceptor model, the interaction between the preceptor and student allows a fuller understanding and assessment of the student's knowledge and skills and provide timely feedback. The 1-minute preceptor is divided into a few micro skills, and we'll evaluate each of these individually. First, get a commitment from the student. Ask open-ended questions and then follow-up questions. Don't judge and be patient. Don't jump in with the right answer or diagnosis. Personally, for me, sometimes I have to sit on my hands and consciously make an effort to keep my mouth shut so that I don't take over the case. That's probably the New York in me. Secondly, probe for supporting evidence. Again, we're still waiting and still not taking over the case. Gently probe for an explanation of why the student has come to the conclusions they have. Again, kind of open-ended, why do you think, and what led you to that diagnosis? Okay, if I haven't already lost you on those first two, let's move on to teach general rules. Don't do a deep dive into a topic. Just stick to some general principles or clinical pearls and direct them to information sources such as class notes, journal articles, or textbooks. Fourth, provide positive reinforcement. Everyone appreciates positive reinforcement, but today's students crave it. And as I mentioned earlier, this lessens some of their anxiety during the clinical interaction. Fifth, correct mistakes. And again, be specific in those comments. Avoid statements like, "Did you ever go to that class?" or "You are just terrible." Try to correct errors in a non-condescending manner. Lastly, have them take a moment and think about their own performance. They're usually pretty self-aware and know what they did well and what they need to improve. My impression is that they're often tougher on themselves than I would have been. This is the 1-minute preceptor. This approach was first described by Naher, Gordon, Mayer, and Stevens in their published article, A 5-Step Microskills Model of Clinical Teaching in 1992. Their model included the following microskills for a preceptor to focus on when cases are presented by student clinicians. 1. Get a commitment. 2. Probe for supporting evidence. 3. Teach general rules. 4. Reinforce what was done right. 5. Correct mistakes. Let's review these steps as it pertains to optometry with this video demonstrating a student clinician presenting a case to an attending about a 20-year-old patient who presents to the urgent care clinic with complaints of headaches. He's just completed the exam, noting she has optic nerve head swelling bilaterally. He's hesitant on how to proceed as this is his first time seeing IIH in clinic. Get a commitment. Try to ask open-ended questions. Refrain from giving your opinion without hearing theirs, and ask follow-up questions. Try to be patient and let your student present their thoughts first.
Hey James, I was following along with the case. I'm surprised you didn't get an OCT or visual field. You should have had those done by now.
Okay, let's stop and review this video. We are all guilty of taking over cases and telling students what to do before they get a chance to present their ideas. Let's rewind and see if we can ask more open-ended questions first.
So James, what do you think is going on?
I think this patient has IIH.
Probe for supporting evidence.
Okay, so your top differential is IIH. What clinical findings help support that decision? And was there anything else that you ruled out today?
Well, she fits the bill for IIH because she's female, in her 20s, and she has a high BMI. In addition, she has bilateral disc edema, and I've ruled out migraines, binocular vision issues, and accommodative dysfunction. So I was thinking if we could we send her out for imaging and a lumbar puncture?
Well, that's a good thought. Is there any additional testing you want to do today?
I don't know.
Now that the preceptor's gained additional information, both about the case and the learner's knowledge base, she can teach in a targeted way. Number 3 is teach general rules. Try to refrain from overwhelming learners by reteaching conditions. Instead, focus on clinical pearls so students have a solid understanding of the important take-home points. If the student truly has no understanding of the condition, recommend reviewing it after clinic instead of reteaching it now.
Well, James, your differentials definitely seem appropriate, but before we send the patient out for those tests, let's talk about what additional testing we can do in office today. And let's talk about other symptoms the patient may have. One clinical pearl includes asking about pertinent negatives as it relates to symptoms associated with IIH, such as tinnitus, diplopia, temporary loss or changes in their vision, nausea, vomiting, dizziness, or back, shoulder, or neck pain. Also, an OCT and visual field can aid in our decision making when diagnosing this patient and aid in our management of this condition as we monitor for resolution or progression with these tests.
Oh, yeah, I do remember learning that.
Reinforce what was done right. Students can become anxious when questioned and they don't know the answer. Consider reinforcing what was done right during the teaching general rules step to help alleviate that anxiety.
I do want to commend you on asking height and weight and acknowledging that her BMI is elevated. That was a great follow-up question after seeing the bilateral disc edema.
Thank you.
Correct mistakes and be specific. Go over the case, highlighting areas where the student can improve.
Okay, let's review the OCT and the visual field findings. IIH is a diagnosis of exclusion, so we do need to make sure we evaluate the patient completely before concluding that it's papilledema owing to increased intracranial hypertension. Let's go take a look at the patient.
Sounds good.
So to review, here are the 5-step micro skills. While this teaching method cannot be applied to every scenario, it's a great tool for clinical teaching to evaluate a student's knowledge base and independent clinical decision-making ability. So in summary, it's essential that as clinical educators, we not only understand the attitudes and behaviors of this generation of students we're teaching, but adapt to their preferred style of learning and communication, even if it is at odds with our own. We can't assume they understand generalities. We need to be specific with expectations as well as provide immediate feedback, even if that feedback is critical, in a constructive and supportive manner. To today's students, the absence of feedback is equivalent to positive feedback. It's important to them to be part of the team, so include them in the treatment and management of patients. And finally, understand your role in the development of the student as a doctor. They're watching and listening to everything. I was given this as a gift by my friend and former colleague, Dr. Catherine Lynch, and I keep it on my desk as a daily reminder of my why, or at least, why not? On behalf of myself and Dr. Patel, we thank you for your attention, and we're happy to answer any questions.
Thank you, Elise and Jiminy, for that excellent presentation. I really appreciated that you included the videos there at the end. So thank you very much for that. We do have a few questions here, and if anybody has any questions that they'd like to submit, please submit them now. One of the questions is, what is the proper protocol if a student discloses to you that they're not doing well in clinic because of a mental health condition? You know, especially this year in particular, I know personally I've seen that in some of the students. So do you have any suggestions on how to handle that?
Yeah, this is obviously something that happens more often than I think any of us like to see. And while I appreciate the trust that they're putting in me by, letting me know what's happening with their mental health, I have to recognize that I'm not a mental health expert and I need to know where the proper resources are. Fortunately, ICO has now an on-campus mental health service that is available to all students, whether it's an acute situation or something more ongoing. And you're absolutely right, Greg, when it comes to the pandemic, this is a service that's being taken advantage of more and more. And fortunately, they were able to go remotely really, really quickly.
Thanks. Another question is, what has been your most effective clinical teaching tool?
I think I would say a couple things. One is, as I mentioned in the presentation, it's not answering my own question, because hopefully I know the answer to my own question. I think it's learning how to ask a student a question and be patient. Perhaps just giving another kind of gentle prompt, but not talking over them. What I try to tell my students at the beginning of the quarter, especially earlier third years, and certainly second years, is it's not that important to me that they always have the right answer. It's more important that I see their thought process. So I think that helps take away some of the anxiety that they feel, and can see me as a team member and very supportive. And another thing is just doing that meeting with students outside of clinic, kind of getting that one-on-one, so I can learn a little bit more about them, whether it's personally and as well as their clinical strengths and weaknesses, and they can learn a little bit more about me that way as well. Especially remotely, they know now, like, my kids live at home and they graduated from college. My dog likes to bark at the postman. It makes me more approachable to them. And the ones that I've done so far for winter quarter, every student has said, I really appreciate that you give me do's and don'ts, because it is really challenging to walk into a clinic the first day and have really no idea what that attending wants or expects. So I think that meeting helps kind of establish a professional but friendly relationship, and gives us a chance to also find out kind of what their goals are for the quarter. And so that's something that we can kind of circle back to at mid-quarter and at the end of the quarter, so we can know if they've met those goals together. I hope that answered the question.
Very much so. I mean, thank you. And I kind of, to piggyback on that, I've seen, I think we've all seen, some students that are, like rock stars in the classroom, but they get to clinic and they struggle to put it together. It's just like there's some type of disconnect. And on top of what you've, already kind of told us when you answered the last question, do you have any suggestions on I hate to say to give them a reality check, because that sounds so harsh, but do you have any suggestions on kind of like bridging that gap so that they can realize, I do need to work on this a little bit more?
Yeah, so I'm actually going to answer that one. I work with a lot of the remediating students, especially the fourth years who are off campus. And my first step, as one of the other presenters had mentioned, is just self-reflection. Them understanding that, okay, this is what they would do in clinic, and then this is how they think they did today. Then I take a minute and say, this is how I think you did today. Here's the actual diagnosis, or here's how I would treat it. And I'm not saying that every time they learn from it, they feel like there's a big disconnect from what I'm saying versus what they're saying, but it's so often that students who are doing well in an academic setting and the didactic side of things realize that, oh, I definitely missed the big picture here. I can learn from this, or I think I need to work on this. And that has worked really well when I remediate the students. I usually start with a case, have them work through it, self-reflect, and then I jump in. I try to stay quiet during the first half of it, so I don't give my opinion of it. I don't try to sway their decision of their self-reflection of how they did, and it tends to work really well.
Excellent. That really helps me. And another question that was submitted: what app or program resources are available if you're considering altering teaching styles to be more accessible to students?
Sure, absolutely. I'll take that one as well. To be more accessible to students, so I definitely during COVID learned a lot about the different apps available and had to teach myself exactly how to use them, what was out there. One of the big things that I found helpful was remote office hours. The first step of that was adding my schedule on Outlook so that students could directly see when I was available, when I was not available, and they could schedule appointments in those open slots that I had accessible to students. In addition to that, I use that to kind of decrease the back and forth of what time worked best. I know some people use like different polls like Doodle and things like that, but I felt like that was very, very helpful. The other thing is office hours, remote office hours specifically, when students are struggling is so, so helpful, especially in a clinic setting, because they can watch me do a chart and they can ask specific questions related to the chart because I can share my screen and kind of walk them through it. It's so often where we see patients in clinic, the student works on the chart, and then we work on the chart and include those comments in MetaCheck. But there might be a disconnect if they don't understand exactly what you're saying. So to do that live, I found that helpful, at least when we returned back from remote to being in person. I did that the first week of the clinic, and the students absolutely loved it. I wish I had the time to do that every single week, but at least for struggling students, that could be definitely beneficial.
That's a great recommendation. So I think we've all been there, and I think I'd like you to answer this mostly for maybe the younger, faculty or clinical faculty. But if you get any of those sort of negative attributes, that you had in your word cloud in your reviews, where do you start to work to change that? I mean, because that's tough, and that really hurts when you get that. So, do you guys have any suggestions on, kind of how to pick up and rather than take it so personally, just sort of moving forward with it?
Yeah, I think it's hard not to take it personally though, right? I mean, we're working so hard, especially under, these conditions, but even before COVID, we're all working so hard. No one likes to be called condescending. But it's better than my personal favorite, which was snarky. And it was actually snarky. It was actually snarky that kind of was a tipping point for me a few years ago where I had to be open to the idea that maybe there was something to these comments, so instead of, the knee jerk reaction of like, you know, they're just wrong, I had to kind of reflect the same way that we ask our students to reflect on their performance. I really had to reflect on my own performance and realize like whatever I was doing, even it just came down to, the message might be good, but, if the messenger was not spelling it out in the right way, then that message was going to fall flat. And as I said in my presentation, if I want to do a good job and I want to be fulfilled in my job, then changes needed to be made. And I really had to make a conscious effort to take those to heart, not take them personally in the way that we can give constructive criticism to students. And we're like, it's nothing personal. It's not whether I like you or not, it's not about that. But this is my job, and my job is to teach, and to be an effective teacher, I have to maybe sugarcoat things a little bit more. And I have to say, I still get the condescending and rude every once in a while, but hopefully, Dr. Teitelbaum, if you're listening to this, you can see that my reviews are a little bit better than years past.
Very good. So thank you for that. I know my favorite review was, oh, it was better than last semester, but still not great. So all right. Well, everybody, we are about I think 6 or 7 minutes ahead of schedule. So I'm just going to go ahead and move on forward to our fourth and final presentation of the day. This presentation I saw initially at the 2019 Academy meeting in Orlando. And I was just blown away by its content and its relevance. And when I went to this lecture, I honestly thought, okay, there was going to be like 5 or 6 of us. And it was literally standing room only. And that was one of the moments that I've been so proud of our profession. But But working with transgender patients is more common now than ever. And this presentation, Respectful and Informed Communication with Transgender Patients by Dr. Kalazinski and McDowell, will give you a solid background on how to effectively and compassionately work with this population. So I'll now hand the presentation over to Dr. Kalazinski and Dr. Paula McDowell.
Hello everyone, thank you for joining us today. I'm Dr. Paula McDowell and I'm here with Dr. Lillian Kalazinski, and we're both associate professors at the Michigan College of Optometry. Today we're going to talk a little bit about respectful and informed communication with transgender patients, and this will be kind of a broad overview focusing more on the communication aspect. Dr. Cal and I have both been seeing more transgender patients in our own clinic, and we tend to find that while students are pretty comfortable with the terms and the concepts from a social standpoint, they really are not comfortable with how to work with a transgender patient from a clinical care perspective. So hopefully this will give you some good information to help you be able to educate your students and teach them about the best way to communicate with this population. So because respectful communication is informed communication, we're going to start out talking a little bit about terminology. So when we look at terminology, there are a lot of different terms that are out there and they are constantly changing. So we're just going to go through a few of the most common, the few that are the most important for you to know. So the graphic that I have here is from Mayo Clinic, and when we use these terms, we're really looking at how an individual defines themselves or different ways that somebody can define themselves. So the first term at the top is sex, or another term for that is assigned sex at birth, or sex assigned at birth is what you will often see. And just like the term says, this is something that is assigned when an individual is born. Typically this is based on chromosomes and anatomy, and most frequently individuals are assigned to either a female sex or a male sex. However, we have several individuals who are somewhere along that spectrum that maybe have extra chromosomes or have indistinct anatomy, so those are referred to as intersex individuals. So with sex and with all of these different categories that we're going to talk about, we really shouldn't think of these as being or only having two specific options. Each of these categories can really be thought of as more of a spectrum where you have two ends of the spectrum, but there are a lot of different things in between. Gender identity is an individual's internal sense of being male, female, or again, somewhere along that spectrum. Somebody who is a somebody who is a cisgender individual is somebody whose gender identity matches with their assigned sex at birth. So somebody who is assigned a female sex at birth and identifies as a woman would be a cisgender woman. Now, it's important to note that most individuals have that internal sense of being male, female, or somewhere along the spectrum. They have that internal sense by about 6 years old. So this is not just something that individuals are choosing on a whim. It has been shown repeatedly that this is something that is an internal sense of being male or female, and isn't something that individuals are just choosing. So a transgender individual is somebody whose gender identity does not match up with their assigned sex at birth. So an individual who is assigned the male sex at birth but identifies as a woman would be a transgender female. When the gender identity or the individual's internal sense of being male or female doesn't match up with their sex assigned at birth, that causes gender dysphoria, which is the specific medical term when the gender identity doesn't match the sex. Just like sex assigned at birth, though, individuals may identify as a woman, as a man, or somewhere along that spectrum. So maybe they are assigned a female sex at birth, but they don't strictly identify as a female or a male. That would be a gender fluid individual or potentially a non-binary individual. So the terminology that we're seeing most frequently in the literature now is transgender and non-binary, or TGNB. When we look at gender expression is the way that an individual will manifest oneself through the social norms of masculine, feminine, or again, somewhere along that spectrum. So somebody may choose to express their gender as more feminine, as more masculine, or really as neither, or sometimes as one, or sometimes as the other. So we really can't make assumptions on how an individual looks about what their gender identity is. This brings us to the topic of sexual orientation, and sexual orientation is definitely a part of an individual's self-identity. However, sexual orientation has nothing to do with gender identity. It's a completely separate topic and really doesn't have any influence one way or another on gender identity. So again, when we're looking at terminology, the terms are changing a lot. When you look back in the literature, you will see some terms that are outdated, some terms that are no longer used. So it's important to be aware of those if you're looking back through old literature or trying to find some information on your own. Keep in mind that sex and gender identity are two separate things. Gender identity and sexual orientation are two separate things. And while they all help an individual define themselves, they are very, very separate components. Last thing that you should really be aware of when we're looking at terminology for transgender individuals is using appropriate pronouns. And these are a few that I have listed at the bottom: he, she, they, and they. I want to point out that one specifically because in September of 2019, just about a year ago, themself was added to Merriam-Webster dictionary as a gender-reflexive singular gender-neutral reflexive singular pronoun to be used in place of he or she. So an individual who is gender fluid, who might not specifically identify as female or male, might choose to identify themselves as they. Pronouns should be used based on an individual's gender identity and not their sex assigned at birth. So if a patient comes into your practice and they say that they identify as a male, then the appropriate pronoun for that person would be he. Same thing, if somebody comes into your office and they identify as a female, regardless of what their sex assigned at birth is, that individual would want to be identified as a she. And the best way to figure out which pronoun to use is to simply ask the individual how they identify. The last thing that's very important to note is that patients should be called, individuals should be called by the name that they choose for themselves. So very similar to, you know, if you have somebody who's named Richard and they come into your office and they want to be called Rick, that's something that is pretty common for us and for our students to say, okay, I'm going to call you Rick. The same is true for transgender individuals, and Dr. Cal will talk about the legal changes in a little bit, but you should always refer to individuals by the name that they want to be called. So again, regardless of what the patient's sex is or what some of their legal paperwork may say that their sex was assigned at birth, you want to make sure that you are referring to an individual by the name that they choose. If you refer to an individual by a name that is of a different gender identity than what they currently identify with, then it's called dead naming, and it's a very offensive practice and something that you want to avoid at all costs. So for instance, if you have a patient who is assigned a male sex at birth, and we'll use Richard again, they were given the name Richard as a child, but they identify as a woman and they now go by Frances, then if you were to call that individual Richard, you would be dead naming that individual, and again, it's very offensive. So always make sure to refer to individuals by the name that they want to be called. So we're going to switch gears a little bit and talk about demographics of the transgender population. And I know that this is not specifically related to communication, but I think it's really helpful from the informed perspective to have some understanding of what this population looks like or what some of these demographics look like. So the information that I have on this slide is taken from the U.S. Transgender Survey, which was a survey done in 2015 that surveyed 27,000 adults across the United States. And what they found in the survey was that the transgender population makes up anywhere from 0.39% to 2.9% of the U.S. population, and generally about 3.5% of the LGBTQ population. What they found in this study was that transgender individuals have very high rates of physical abuse by others, very significant barriers to healthcare, including about 13% of respondents reported that a healthcare professional at some point tried to stop that individual from being transgender. Very high rates of poverty and unemployment, very high rates of substance use and abuse, and very high rates of behavioral health issues. And if you look at the graph that I have on the right here, you can see the statistics for the transgender population from this study compared to the general population. I think most surprising or most alarming to me are those first three numbers looking at serious psychological distress, 5% of the general population compared to 39% of the transgender population. Suicide attempt in a lifetime, 4.6% of the general population compared to 40% of the transgender population. and suicide attempt within the past year, 0.6% of the general population compared to 7% of the transgender population. So we do tend to see a lot of behavioral health issues with this population, which is not inherent in being transgender, but I think it's easy to understand how barriers to healthcare, physical abuse, poverty, and unemployment, because of some of those discrepancies, can certainly lead to those behavioral health issues. The good news is that we have many ways to minimize those discrepancies, and the information under that last section is from the Trevor Project, a survey that was done in 2019 looking at 26,000 transgender youth from 13 to 24 years old. And what they found was that family acceptance, use of an individual's chosen name, social transition, and appropriate medical care can do amazing things for minimizing those discrepancies. So to give you some examples, for family acceptance, suicide rates decreased from 57% to 31% in highly accepting families. So 31% is still a high number, but it's a heck of a lot better than 57%. Use of an individual's chosen name, we had a 29% decrease in suicidal ideation and a 56% decrease in suicidal behavior. Looking at social transition, children who have transitioned demonstrate comparable levels of self-worth and depression as non-TGMB individuals. So again, just having somebody who is accepting, having somebody, having a good support group can significantly decrease those discrepancies. And then finally, appropriate medical care, where we see behavioral problems reduced from 44% to 22%, and significant emotional distress decreasing from 30% down to 11%. So with that, I'm going to switch it over to Dr. Cal to talk a little bit more about what is social transition and appropriate medical care.
Hi everyone, this is Dr. Lillian Kalazinski, and I am picking up where Dr. Paula McDowell left off. I'm going to speak with you today about gender transition. Transition is the process of aligning our internal identity with the outward appearance, and experts certainly do indicate that psychological, hormonal, and surgical care is associated with significant improvements in gender dysphoria and decreased psychiatric comorbidities in our transgender patients. While our graphic at the top would indicate that transition is a very smooth and sequential process, it actually is much more reflective of the graphic at the bottom. It is highly individualized and somewhat of a mismatch. So not everyone is going to go through each one of these stages that I'm going to talk about with you today. Many transgender individuals will have undergone some type of psychological therapy, either past or present, and many will undertake cosmetic and social transition, which is simply changing hair and makeup, changing the way they dress, changing accessories. This might also be the stage at which they start using a different name or pronoun, even if they have not had their name legally changed yet, okay? Moving on, about 80% of our trans population will undergo gender-affirming hormone therapy. And I do want to speak with you a little bit more about hormone therapy because they can have some ocular effects. So depending on the age of the individual, if they are a young individual, prepubescent or an adolescent, most likely they are going to be starting with something called hormone blockers. And these are medications that are used to delay or stop the development of secondary sex characteristics in gender questioning adolescents. So this has two benefits. Number one, it allows this individual to kind of put off making any final decisions, so to speak, until they might have reached an older age. Okay, so many of these young gender questioning individuals will go on to become transgender adults. It is very well documented that most children that are gender questioning do in fact transition at some point. I don't have that exact percentage in front of me, but it is a high percentage. But in order to to make any final decisions in surgical corrections and things like that, they're put on hormone blockers. And that has the added benefit of preventing the development of our secondary sex characteristics. So for many of these youth, when their outward body starts to be a complete mismatch to the way they feel on the inside, it can be very traumatizing, and where we can start to see those psychological risk factors really start to come to the forefront. So if we can delay that for our youth, it's preferred to do so. Moving on to our masculinizing hormones, I'll just remind you what our DEUCE-2 study reported, which is simply that androgen hormones typically improve many many components of ocular surface disease. So as we increase the androgens, typically our ocular surface disease and dry eye problems improve. There has been a link in the literature, it certainly is well known at this point, that taking exogenous testosterone might contribute in some way to the development of idiopathic intracranial hypertension. There are a good number of cases in the literature now of transgender individuals, so trans men transitioning from female to male, taking exogenous testosterone, have developed a form of IIH. Not well understood. The pathway has still not been figured out yet at this point. Fortunately, most of these individuals respond very well to our traditional treatments of weight loss and oral medications, and they very often do not even have to stop the hormone treatment during their treatment for IIH. So more to come. It's definitely an area of active investigation at this point. Moving on to our feminizing hormones. This can be estrogen as well as something called anti-androgens. The most common are going to be spironolactone in the anti-androgen class. Again, hearkening back to our DEWS-2 study, we do know that early evidence indicates that estrogen does decrease meibomian and lacrimal secretions. So for trans females, we might expect to see their ocular surface and dry eye conditions actually worsen. Anti-androgens, the spironolactone, really does not seem to have any additional impact on the ocular surface at all. So to summarize, watch out for changes in ocular surface conditions and dry eye conditions, and pay attention to strange cases of IIH. Try to confirm whether you might be dealing with a trans male if you do encounter one of those cases in your practice. Gender confirmation surgery is undertaken by anywhere from 25 to 35% overall of transgender individuals, much more common in trans men, so those individuals transitioning from female to male, probably because the surgeries that would be involved in transitioning to female to male are surgeries that are much more common. Doctors have been doing breast augmentation and breast reduction for a very long time. It's the same procedure. Whereas those surgeries may be needed by trans women tend to be more invasive and more specialized care that not as many doctors are familiar with. And it's interesting to note that 9% of individuals that identify as non-binary do have some type of surgical confirmation at some point as well. Finally, to speak with you about the last step for most individuals, that's going to be our legal transition. And legal transition includes a legal name change, if possible, a change in our legal sex indicators, as well as just changing documents to reflect our new gender identity. So legal name change is very simple. Anyone can change their name. You really don't even have to have a reason to do so. Changing sex indicator on driver's license and birth certificates vary greatly by the state of residence. So some states are now allowing individuals to have a non-binary sex indicator on their driver's license. So instead of male or female, you might see an X on a driver's license. That's coming down the road in several states, even if it is not a completed process yet. And then finally, whether an individual can change their birth certificate or not, it also depends on what state you live in. This is probably the hardest step in the legal transition. Some states that do allow an alteration in the birth certificate don't even allow male to female, female to male. It's more changing to a non-binary option. And it typically does require full transitions. So individuals to go through full gender confirmation surgery before it's even a possibility, and time consuming and very costly. So the last step, and probably the most important part of this lecture, is talking to you about how to create a gender inclusive practice. There are certain steps that we can all take to help make our transgender individuals feel much more welcome and at home in our practices. The first one is just to increase awareness, what we're doing today. Increase awareness not only for yourself, your providers, but also your faculty and staff, as well as your students. Another very easy change is to always use gender neutral pronouns. We've got an example here of a sign that could easily be swapped out in your clinic to make our restrooms, gender welcoming. Finally, address people by their preferred name. We've talked a bit about dead naming. That is a very alienating practice to continue to call someone not only by a name that they no longer recognize, but a name that is maybe associated with a gender that no longer pertains to your patient. So address people by their preferred name at all times. Standardize your documentation protocol. Change your intake papers, ask every patient the same questions on intake. We all know that nothing becomes standardized until we do it on everyone and do it the same way. So this won't become part of your practice until you standardize those processes. If you do have a transgender individual and you don't quite know what is going on, don't be afraid to admit your ignorance. However, I will say, make sure that you don't count on your patient to be your teacher. It's okay to admit your ignorance, but you need to do your own research. Everything indicates, almost every patient testimonial that we have read basically says transgender patients, they get it, that, this is a new thing. You might not be very experienced or comfortable with it, but don't count on them to teach you what you need to know. You've got to do your own research. Finally, something that's very easy to overlook, don't forget about your frame board options and try to not reference your frame boards as the women's frames and the men's frames. Come up with different gender neutral terminology, have something in the middle. And again, we have learned through talking with people about this topic that eyeglasses are a big part of the social and cosmetic transition. So you really could market your practice simply by having great frame options that would appeal to transgender individuals or people that maybe want a gender neutral option. So think about that as well. So Paula and I hope that you find this information helpful. It's been our pleasure to speak with you today, and we look forward to answering your questions.
Paula and Lillian, thank you so much. I'm so impressed by this lecture, and thank you for bringing it to the OCEF of 2020. We do have a few questions here. If anybody has any questions, feel free to type them in the box. But the first one is, what has been the biggest challenge either of you have faced while creating a gender neutral practice?
Sorry, I was having some.
I think can certainly add on here, but I think. Oh, there you are.
Yep. Sorry.
That's
I was
all right.
having some difficulty unmuting. I apologize for that. But Paula, if you want to jump in, and I can follow up with you.
I think the biggest challenge that we've had is just really making sure that everybody is educated in the clinic. So, we've talked to our students a little bit, but I think it's been very unusual for some of our staff to start asking some of these questions. So I think the biggest challenge is just bringing awareness to everybody in the clinic, including other faculty, our students, the front desk staff, and just kind of reiterating some of these concepts over and over again, like Dr. Cal said, so that it does become part of the routine and not something weird and different that the staff have to ask questions that they're not used to asking.
Yeah, I agree completely. And I would also add for many of us, particularly if we were, raised with a strict parent on the grammar, getting used to different pronouns is really a huge stumbling block for some individual, myself included. The first several times I gave this lecture, I lived in fear that I was going to say something offensive because, our grammar is something that's ingrained, as an adult. So making those changes has been a challenge.
Thanks. I have a kind of a question of my own that I just wanted to piggyback onto this. So, have you done any type of outreach to the transgender community? And if so, how do you assure them that, they're coming into a clinic that is a safe space?
Yeah, that's a great question. So Paul and I both practice at the Michigan College of Optometry, which is at Ferris State University in Michigan. And we are really fortunate that we, have the resources of the larger university at our, to our advantage. And so we actually did have a meeting earlier in the year with the director of our LGBTQ Resource Center on campus. And she has been a wonderful advocate of what we are trying to do at the College of Optometry. And unfortunately, right before just prior to our shutdown due to COVID, we were actually in the initial planning stages of an interprofessional training that we were going to host with some of the other healthcare professions on campus to also spread this information to other curriculums. And we hope to pick up that planning, as soon as the world gets back to normal.
Very good.
If that ever happens.
Yeah, not so sure about that.
Yes.
Just
I would add to that. Oh, sorry. I would add to that too that we have also recently kind of reformatted our intake forms. So we haven't done a whole lot of outreach in the community, but we are starting to change our intake forms so that becomes part of the routine questioning. Where we ask every single patient that calls in for an appointment, okay, what's your sex, and also what is your gender, what is your pronoun that you use, so that patients know right when they call in that that is something that we're thinking about and are aware of when they come into the exam room.
Okay. We've had a couple questions just pop up right here. One is a restroom question. It says, we don't have an option to create a separate gender inclusive restroom. Did you actually put in a new restroom?
We are fortunate that we are in a beautiful new facility, and so our patient restrooms are all gender neutral, and they have been from the beginning, and we are very fortunate in that way.
Well, that's cool.
Yeah.
Another question, it's very difficult in Spanish to keep up with the pronouns. Do you have any advice? Is it just kind of like in English, just practice, practice, practice?
It's been tough for us to keep up with those too. One thing that we did on the intake form, rather than try to list out all of the possible pronouns that somebody could select, we just said, list your pronoun. That way, if it's something other than he, she, or they, then the patient can just write that down and we can use that.
Have you had any type of pushback from patients, staff, or students about sort of the operational changes that were needed to be more receptive and inclusive of transgender patients?
We really haven't, not to my knowledge. I do think we just had some general anxiety about asking the questions. But now that we have been talking about it more frequently, with all of the stakeholders basically in our college, I think everyone's getting much more comfortable with it. I will tell you that some people were concerned that we would offend some of our perhaps older patients that we do serve in the clinic. And it has not been an issue yet. I'm sure it might be at some point in the future, but it has not been nearly as much of an issue as we were afraid of.
That's nice to hear. When or where do you think it's an appropriate time in the curriculum to educate students about this topic?
I think there's a lot of opportunity for this. I think it fits really nicely into a cultural competency portion. So whether that's in your public health course or a patient communication course, I think that would be a good spot to include this formally. But I think for us too, it's also been kind of nice to include the topic informally in other presentations. So for instance, I mostly teach in pediatrics, and I have a little section that I give about prescribing to pediatric and pregnant patients. So I add in there, don't forget about your transgender dads or patients that were assigned the female sex at birth, able to carry a baby to term, and just reminding those students about those concepts throughout the curriculum so that it's not just one thing that they get in one piece in one part of the curriculum.
Very good. One final question, and I know this has happened once in our clinic, and I was so mortified, but have you had instances where you've accidentally dead named or misgendered a patient? And, were you able to smooth that over with the patient? I mean, how did you do that?
Yeah, this was actually one of my very first experiences with a transgender patient was about 10 years ago, and I misgendered the patient at the very beginning of the exam, but I don't think it was quite as common a concept. So the patient was very forgiving, but I kind of ignored it throughout the rest of the exam, and that was a really terrible way to handle the situation. But now, certainly if that happens, I've had students that have come to me after the fact that have misgendered patients, and that, they apologize, and then just kind of make sure that you update your terminology for the rest of the exam from there on out. Make notes in the chart so that it doesn't happen again. And Lil, I don't know if you've had any similar types of experiences.
Thankfully, not that I'm aware of. But again, I think in our conversation with, transgender friends and individuals that we know, and I have to say, it's been amazing the outreach that we have had from transgender colleagues after we gave this lecture the first time at Academy. And again, we just gave it a second time, and more outreach from colleagues. So people have been very, willing to share their expertise and their information in this area. So our knowledge has grown exponentially in the last, 18 months about this issue. Really, this is a very forgiving, population. They expect us, sadly, they expect the healthcare community to screw this up. So I think if it happened, my best advice to you would just be to apologize. And like Paula said, do every single thing you possibly can to make sure it never happens again.
Fair enough. So the questions are rolling in now. Let's see here. Any advice in terms of how to deal with a student that sometimes dresses up as a female and other days as a male, mainly at the clinic?
Well,
That's a good question.
at the risk of, I'm not trying to sound flippant here, but I wouldn't comment on it any more than I would on the appearance of any other student. I mean, unless it's inappropriate dress, that violates your clinic dress code, then of course I would address it. But if they're just changing their identity for the day, I just wouldn't address it.
Might be helpful too, if you're working with students, if it's somebody that you're working with individually. One of the presenters earlier was talking about having like a Q&A before clinic to kind of gauge the students' goals. I think it would be nice to do kind of a get to know you thing and include those same types of questions that you would ask your patients to your students. What pronoun do you use? And then that might help kind of you as a clinician understand where that student is coming from.
Okay. Next one. Oh my God, I love this question. So how do you tread the line of needing to know birth sex for medical care, like X-linked diseases, et cetera, while being respectful of preferred pronouns?
So
I don't know if you want to take this one.
Yeah,
and
no,
kind of
I was trying to think about how I wanted to explain it. So the way that we have approached our protocol at the University Eye Center is that we ask about assigned sex at birth, and then we ask about preferred gender. So I think if I had a patient that I knew was transgender, I would just have a very open conversation with them, and I would just start off by saying, the reason that I'm asking these questions is that we do know that particular diseases affect, particular biological sexes, or however you want to phrase that, whatever term you're comfortable with. And so I'm asking from a point of wanting to deliver the best care that I can to you, and that is why I have to ask more, sensitive questions. I guess I would just be very matter of fact about it, but I would explain why I'm asking. Paula, would you do anything different?
Yeah, that kind of goes along with the patient privacy too, and having that conversation with the patient so that they're aware of what's going into the record. That way, if they get communications from the clinic, they're kind of aware of what is coming to them as far as gender and sex, or insurance companies making sure, like Lil said, making sure that that matches up so that they can actually get that exam reimbursed through the insurance, so that there isn't a disconnect between what the insurance has on file and what the clinic has on file.
I guess the follow-up to that question for me would be, is this someone that you are assuming is transgender, or is this someone that has disclosed that they are transgender? I think those are two different contexts.
I mean, the way it's phrased is, I think it's, that they are.
Yeah, then I agree with what Paula said, and I would hold with my original answer. I would just, it's very similar to me to having to have a conversation about a, potential, I don't know, STI or something like that. It's just one of those sensitive conversations that you're going to have respectfully.
Sure. Just so that somebody posted a statement about the question about the student. I think the question about the student who dresses differently may have been more related to which pronoun to use. I think the obvious thing is to just ask, what pronouns do you use?
Got it. Yes, that makes more sense. I would agree with that. I would just ask.
Makes a lot of sense. I really want to thank you, Paula and Lillian. A lot of interest in this, a lot of questions that we've got them all. Thank you so much for your time. And that concludes our OCEF 2020 Online Clinical Education Forum. I'm going to finish out here. So one thing, please make sure that you share with us your thoughts about today's program. A lot of the content today came from the information we received from past surveys, kind of what you like, kind of what you didn't like. So if you would fill that out, we would be very grateful. And we would like to thank you to our 2020 OCEF presenters. I think everybody did a fantastic job, and I want to personally thank each and every one of you guys for volunteering to do this and for helping us out. And also a special thanks to our OCEF liaisons at our ASCO schools and colleges of optometry. And finally, I'd like to thank the 2020 OCEF planning group members. It was a group effort. We all worked together on this. And a very special thanks to Alex Job at Log Me In, who helped us through a couple of dry runs this week. Also, the Clinical Affairs Committee members for 2019 and 2020. Thank you, everyone. And we appreciate that. And we'll look forward to doing this again next year.